Afternoon, everybody. I think we'll make a start, although I think we've got a few more that might just join us in the next few moments. A very, very warm welcome to you to our event, Medicine and Me, and a really big warm welcome to the Royal Society of Medicine. So I'm Charlotte Osborne-Ford. I'm the Chief Executive here at the National Academy for Social Prescribing, and I'm really proud to be saying that we're working in partnership with the Royal Society of Medicine for the first time to deliver this joint event. And I should say that it was the Royal Society of Medicine that actually contacted NASP, as we call ourselves for short, about this event, saying that they had an interest in social prescribing. Members were asking about social prescribing, and would they work with us to do a joint event to share knowledge about best practice, about people's lived experience of social prescribing, and about the latest developments, initiatives and policy. So our answer was, of course, yes, absolutely, we'd be delighted to do that. And I think for us, this is very symbolic of a real turning point in social prescribing, which really evolved as a community movement over decades, but which has seen a real acceleration in terms of healthcare policy and integration over the last 5 years. And now, instead of being seen as something very much as an alternative and on the side of traditional healthcare, of clinical healthcare and medicine, we're really moving much more to a space of integration, which is best for both movements. It's best both for the community and for the medical movement. And of course, it's better for patients to have choice and to have a range of options and opportunities. So you're going to hear today from a range of our colleagues and partners talking about the practice of social prescribing. What does it look like when it is actually delivered? What is the experience of social prescribing for people that have used it? And what is the evidence, which is the other big challenge that we have? So when I talk about social prescribing being at this sort of tipping point over the last 5 years, I think that's for a number of reasons. We have seen government NHS investment into social prescribing in the form of link workers in primary care, and we have seen investment into programs and pilots to test and understand the impact of social prescribing, so that further investment and further integration can be justified, can be warranted. And that is the biggest challenge that we hear at NASP from senior establishment figures, whether that is ministers, politicians, civil servants, CEOs of national organisations, or indeed clinicians, both at a senior national level and out on the ground. The same question, the same challenge around evidence. And so over the last few years, there has been significant work in achieving evidence, in gathering evidence, in synthesizing it and sharing it. And there are 3 things I just want to highlight this afternoon that suggest that we are now there with the quality and quantity of evidence. So the first, which you may have seen in the press this week, is the Green Social Prescribing Project. This is a government-funded program called Preventing and Tackling Mental Ill Health Through Green Social Prescribing. Catchy. And it was funded by a range of government departments and Treasury and other organisations. It was a 2-year program, and it's taken a year to complete the evaluation. But what that evaluation shows is really powerful. It was published last Wednesday by DEFRA. It was picked up in The Guardian and in the BBC. And this is the headline from the evaluation, that green social prescribing, so nature-based social prescribing, leads to statistically significant improvements in mental well-being. And what is important about this study is it was over 8,000 people across all regions of England. So it's a really large and robust study. It says, in terms of depression, the cohort mean score reduced from 8.1 to 5.6. That is from a mild level of clinical depression to a non-clinical level. People did experience an improvement in their anxiety and depression symptoms to the point they're no longer meeting the clinical cutoff. So this is the first time I've ever read a study that is of a project funded by government, independently evaluated by a range of academics led by Exeter University, that comes to this conclusion, that for people with mild to moderate mental health conditions that were on the programme, that is what the evidence shows us. And the report actually goes further to state that compared with other interventions for people with mental health needs, behaviour activation, CBT, early intervention for psychosis, collaborative care for depression, nature-based activities appear to be a relatively cost-efficient way to support people across a wide spectrum of mental health needs. So what we here have is at last some parity with the other approaches that NHS and others invest in and deliver. So this will further help us to raise the profile of this as an equally effective, equally accessible intervention that can support people. And you'll hear lots more today about the realities of what that means in terms of experiencing mental health challenges and how social prescribing can be effective alongside other treatment or on its own. The other piece of work which NASP has been working on and which will be published hopefully at the end of September is a study looking at the impact of social prescribing on the health service. And this is the other challenge we hear again and again. In order to invest in social prescribing, we must prove that it saves money compared to other interventions and reduces demand. So we have gone out to NHS systems, to integrated care boards, primary care networks, other parts of the NHS, and we've asked them what data do they have around the impact of social prescribing that they are already investing in. And we are looking at those studies, collating them and drawing conclusions. So far, the conclusion says that overall, social prescribing can reduce costs and health service use. Despite different approaches to undertaking evaluations, reductions in health service use were reported in all evaluations that we were able to access. So again, we no longer need to hear this message that social prescribing, we don't know if it saves money, we don't know if it's a useful part of the system. This report will demonstrate it does, and it is not only effective for patients, it is effective for health commissioners. And now, lastly, we're always told that we need to have a randomised control trial. Now, there's some disputes around whether this is appropriate for social prescribing. Lots of people will say, why do we need a randomised control trial to tell us that supporting somebody who's struggling, that helping them connect to something that matters to them in the community is safe and effective? But actually, we do need that, because that is a challenge that comes from the existing establishment, from clinical bodies, from ministers. And I'm really pleased to say that there is now, for the first time, an 8-country randomised control trial underway, funded by the EU. NASP is a partner in that, so we will be sharing and gathering information, and this is a large-scale, medical-style randomised control trial. So what this picture should be telling us is that 5 years in, we now have the credibility, we have the evidence, we know that this is effective and impactful. So the next question is, where is the equity? If we have this evidence to share that it's impactful and effective, why does the vast majority of people not able to access it? And that is the reality. So the next step for us is using this evidence, using the stories and experiences of people that benefit of practitioners, and making sure that we finally shift the distribution of resources, the distribution of attention and of credibility into this approach and these models. And I think when we've started to look very in a very light touch way at the economic models, it's roughly about 0.01% of government investment in health goes into social prescribing. So we have to shift that dial a long way, and that's really the start of what we want to talk about today, is to really show you how social prescribing makes a difference, to really demonstrate that the impact that it has on patients, and for you to leave the session today as an advocate for social prescribing in your own practice and in your own systems. And finally, just to say a very, very warm welcome to this event, and thank you to my colleagues and partners. Before I finish, I've just forgotten I have to do the practical fire, the fire alarm details. So, before I hand over to my fabulous colleague Monica, I just have to tell you that a fire drill is not planned for today. If you hear the fire alarm, please leave the building immediately. Please be aware there are 2 exits from this auditorium which are clearly marked, and follow the running man signs to exit the building and proceed to the emergency assembly point, and that there are emergency evacuation maps located at the auditorium podium. So just in case anything does happen, we now know what to do and that we're safe. And on that note, I'll hand over to Monica, who is our healthcare integration lead and will be chairing and facilitating today. Thank you, Monica.
Thank you, Charlotte. Thank you, Charlotte, and welcome everybody. Yeah, so my name's Monica Bolton. I'm the Healthcare Integration Lead here at NASP, and it's my challenge to keep everybody to time today as much as we can. But I echo Charlotte's wishes for this event today, and that I hope you have something to take away from it, are challenged by it, and can see exactly how your contributions in whatever walk of life you have can make a real difference to enabling social prescribing to really succeed. So I've just got a slide here to really ground us in the globally accepted definition of social prescribing. For many years, social prescribing, there's been a lot of debate around exactly what we mean by social prescribing. And there's many different forms in which social prescribing can exist, and we see that globally. Lots of different terms that might mean the same thing as social prescribing. But in 2022 to 23, there was a Delphi study done which essentially enabled us to have this globally accepted definition, which I think is always really useful to have as a reference point. I think it can also be broken down into 3 parts. And remember, we're talking about the function here that social prescribing provides. So it might not necessarily be called social prescribing. It is in this country, but in other countries, this definition helps us to really think very analytically and critically about what we mean by social prescribing, and therefore really measure its success, as Charlotte was speaking to earlier. So the 3 parts in which I think this can be broken down to is that trusted individual. And notice that this can happen in both clinical and in community settings. The second part is that co-produced prescription and the support to connect to services. Now, that often happens through the social prescribing link worker in this country. And then the third part is that subsequent support in those services that are often in the voluntary and community sector that have a marked improvement on individuals, that can support people to have a marked improvement on their health and well-being. So I just want to kind of, before I introduce my colleagues, ground us in that definition. This is exactly what we're talking about when we're talking about every element of social prescribing today. And I guess my challenge to you is to see where the difference that you can make in each part of these different, those 3 different component parts of the definition. And yeah. I'm going to now hand over to my colleagues, Hamad and Joelle, who are going to just do a little bit more of an in-depth introduction to social prescribing, as well as some of the evidence. Firstly, Hamad, thank you.
All right. Ladies and gentlemen, it's a pleasure to speak to you all today as the Global Development Officer at NASP, also a graduate medical student, future doctor, but perhaps most importantly, part of the future generation of your health service, the future of the health workforce. I want to talk about social prescribing and its place, purpose, and value in our modern health systems. But before we even get into social prescribing, let's start with a needs analysis. What is the context of modern healthcare? We all know too well, pressures intensify both the demand and supply side of health systems. Issues of retention and recruitment challenges the health workforce, and an aging population grows with an ever-increasing profile of ill health. So much so that by 2040, 1 in 5 of us will be living with a major illness. We are locked in a polycrisis of care. It's characterized by what I call the paradox of modern medicine. We live in an age with more medicines, more therapies at the height of scientific understanding, and yet we're also experiencing an unprecedented burden of illness. See this graph here, published by the Health Foundation last year. The projected level of ill health in England is increasing. By 2040, life expectancy is expected to increase to 83 years, and the time spent living in one major health condition, at least, shown in lightest green, is set to increase even further. Essentially, as our lifespans are increasing, our health spans, the time we spend in good functional health, is actually decreasing. If we look further, health inequalities are poor too. Overall, the number of working age people experiencing major illness is set to grow by 3.7 million people by 2040, and 80% of this increase will be seen in the more deprived 50% of areas. And that goes across all age groups. People in the most deprived areas are going to experience at least a doubling of the major illness than the people in the least deprived areas. And what has been our response What has been the response of the modern medicine cultural zeitgeist? Well, we've medicated. We've medicated and we've medicated. Give metformin for diabetes, prescribe statins to lower blood cholesterols, now even prescribe Zempic or semaglutides to reverse obesity. This graph, this damning graph from the National Overprescribing Review by the Department of Health and Social Care, shows that the average number of prescription items per head in England has doubled over the past decade from 1996 to 2016. All the while, our patients have become a passive entity. In favor of technical skills, they're pricked, pinned, and prodded for tests and bloods and results in hopes of building a clear clinical picture. Their voice and autonomy hushed under the hubris of modern medicine. Studies quoted in the BMJ this summer found that the median time a doctor takes to interrupt their patients is 11 seconds. 11 seconds. We're reminded of the mantra of the father of modern medicine, William Osler: listen to your patient, he is telling you the diagnosis. It seems we've stopped listening. 44.6% of patients want more involvement in their healthcare, and yet the proportion of patients who feel disregarded in their decisions of care is record high at 10%. That's from the Personalised Care Institute. The bottom line is that the unsustainable is not sustained. We admit the sick and tend to the sick. And when we're done, laughably, horribly, ironically, we send our patients back out into the very conditions that cause their sickness in the first place. And it's in this context and consciousness in which social prescribing as a policy and practice has been born out of. The NHS long-term plan in 2019 was committed to boost out-of-hospital care, to redesign and reduce institutional pressure, and give people more control over their health. And with proposals to recruit over 1,000 new social prescribing link workers in place by 2020 to 2021, and 900 referrals to be made. We've overshot that quite rightly to 3,500 link workers now, and 2.5 million people refer to social prescribing. This is a global movement. NASP convenes a 32-country member state international collaborative facilitating knowledge sharing, best practices, and understanding how other countries are also practicing across their different health contexts. And amongst the diversity of this context, we've now also formulated, as Monica quite rightly pointed out, the international definition of social prescribing, defining it as a means of trusted individuals in communities and clinical settings to identify that a person has a non-medical, health-related social need and to subsequently connect them to supports that they're in most need of. In July, NASP also published its second edition of the Global Report with the WHO, and most importantly and crucially, exploring how social prescribing is being practiced in lower middle income countries too, and there's cross-cutting lessons for us there. This afternoon, amongst all the presentations, social prescribing will challenge us to see how we can deliver health and well-being. I find that the best of modern medicine demands both interpersonal and technical skills. Where technical skills use empiricism, interpersonal skills seek empathy. Where technical skills addresses the patient's biology, interpersonal skills analyzes the patient's biography, valuing the principles of holistic biopsychosocial medicine to deliver a comprehensive and compassionate experience of patient care. Social prescribing ultimately is about centralizing, capitalizing, and communalizing a sense of care. Its place, purpose, and value is in instilling validation, connection, meaning, and purpose. Thank you.
Hi, so my name's Joelle Bradley. I'm the Deputy Director for Evidence and Impact here at NASP. Charlotte's already talked about some of the kind of recent findings in terms of the research. But I'm going to talk a bit about the kind of broader, kind of what we already know in terms of evidence and some of the challenges around that. So in terms of the kind of the current landscape, we know that social prescribing started organically. So there's many like local initiatives responding to local needs. So that meant that there were many kind of small scale evaluations and lots of kind of positive stories of how that was working locally, and some evidence of the benefits of the activities like sports and green spaces. But then there was this large investment in 2019 from the Department of Health and Social Care. But at the same time, it was lacking that large-scale, robust evaluation at that time. And also, the investment kind of changed the context of delivery, so it made it kind of more focused on healthcare usage and the importance of understanding the impact that social prescribing was having in healthcare. So in terms of who the audience are for evidence and what are their needs, there's a number of different audiences. So when we're looking at evidence, we have to consider who it is that wants to understand the evidence. So there's obviously the government and government bodies, NHS England. So they're looking at the impact of their investment, particularly at scale, and like I said, particularly the economic impact, so changes in healthcare service usage. And then there's clinicians often want to know about the impact of investment at that more sub-regional level and local scale and against their local needs. So looking at that population health management and how social prescribing is having an impact on the population needs in their local area. And practitioners obviously want to know about what good practice looks like in terms of social prescribing for their own professional development. They may want to know about certain patient groups, the impact of social prescribing for them, or with different specific conditions, how social prescribing can work. And then community groups and patients, we have to remember as well, social prescribing is for communities and patients, and they want to know as well, what is it working and how's it working, and what is the impact of the kind of social prescribing activity. So here's an example of a pathway. One is actually focused on getting people into work, but it shows the different kind of pathways that people go on and the different kind of information it might collect at different points. So this shows kind of individual complex needs being referred from the GP to social prescribing services, but then there's a range of services that they could then be referred on to in the community. And that also means there's a range of outcomes that we might want to measure. So the evidence comes from lots of different places. And this can be a challenge when the data is often in different pockets that are hard to get to. So there's NHS records where we might have demographic information about patients and information about the social determinants of health. Then there's the referrer that may hold data around NHS data, the SNOMED codes around, and then data around secondary care admissions. There's a link worker function that also may hold data. Sometimes they may hold that on a different system as well. And then there's the providers that then referred to. They might be carrying out their own evaluations, but often they're maybe small scale or inconsistent, focused on their own needs or who else they're being commissioned by. So bringing this all together is very challenging. Often also the VCS sector may focus on counting and stories, and that's really valuable in terms of understanding the person's kind of journey, but bringing that data together to tell the kind of the whole story of the impact that social prescribing can be a challenge. So at NASP, we've focused on bringing together the evidence in different themes. So if you look on the NASP website, there's a page on evidence where we've published 15 evidence reviews. So the latest evidence reviews that we've published are around the impact of social prescribing on children and people's mental health, building the economic case for social prescribing. And then we also did a review around the VCSF sector and how to evaluate social prescribing, so looking at the tools that are useful for them to be able to evaluate the impact. So I'll just summarise some of the findings from two of those reviews. So the economic case for social prescribing, this was published last year. So it brought together findings from 19 different economic studies. So 7 of those were around healthcare usage. So we found that in key areas, there was an impact on healthcare usage, such as GP appointments, A&E attendance, secondary care use, and nurse appointments. And often social return on investment was used to actually evaluate the impact. So that looks at the inputs and then looks at the outcomes, both financial and social, but puts the financial proxy on the social outcomes as well, so they can be compared to the inputs. So what we found was that a range of SROI studies were very positive. They found a return of around £2 to £8, nearly £9 for every £1 investment. And some of the more robust studies showed a range of around £3 to £8 for £1 investment. And then there was recently, in 2022, a study of looking at the evidence around children and young people, at that time it was very limited in terms of the evidence base, particularly when you're looking specifically at social prescribing. So there may be similar social prescribing models, which Tracy will talk about later for children and young people. But when we look at social prescribing specifically, the review only found there was 4 published studies. So we have to be cautious because the number is small. But we do know that from those, they were looking positive in terms of the impact of social prescribing, particularly on kind of loneliness and people's mental health. They were often, the studies published were focused on older young people, so older than kind of 17. But we do know that there's more kind of social prescribing activity around kind of children and families that are younger. So this kind of takes us on to our priorities going forward for evidence. So we're looking at how to kind of identify the gaps in evidence in line with our priority areas, so particularly around children, young people, and that economic case. So Charlotte mentioned some of the kind of findings that should be published at the end of September around the economic case for social prescribing from that further kind of in-depth analysis that we've done with ICBs and local areas. We're also looking at working in partnership to fill some of those gaps, so working with, for example, UCL to support evidence that research that they're currently carrying out with children and young people. So there's one a study of children and young people on the waiting list for CAMS and how social prescribing can help them, and also one set in schools where they identify young people that are lonely and how having a social prescribing link worker can help them, and both of them have got control groups as well that be compared to. And then we're also looking at solutions for that kind of larger scale, kind of multi-site data analysis, how we can bring together data from different sources, the best kind of data to use in terms of bringing together that consistent data to really understand on that kind of larger scale. And there's also a national evaluation of link workers that we're supporting as well. So there's a lot of evidence to come out as well, and it's from what we're looking at, it is looking very positive, but it's obviously a challenge to kind of bring together that evidence in a robust way. But like Charlotte said earlier, it's looking really positive at the moment. So yeah, keep your eye on the evidence website, and we have an international evidence collaborative as well that you can sign up to, where we share kind of findings and opportunities as well.
Thank you to Hamad and Joelle. And what you're probably getting is that social prescribing has advanced at pace, and we've come a really long way in a very, very short space of time, and that, of course, brings some of its challenges. Somebody that's been around in the social prescribing world for a little bit longer than that, in part of its sort of organic, pioneering days, is our next speaker. So I'd like to introduce you to Dan Hopewell from the Bromley by Bow Centre. Thank you.
I've got security alarm. No.
I'll stand up at time.
Great, thank you. Yeah, you probably will need to do that, Monica. I'm capable of talking about social prescribing for several hours. But anyway, so great to be here, everybody. And this is a sort of wonderful celebration, I guess, of a sort of staging post, I think, probably one might say, in the development of social prescribing. So I'm Dan Hopewell. I'm Director of Knowledge and Innovation at the Bromley by Bow Healthy Living Centre, where we were one of the originators of social prescribing. I don't think anybody can claim to be the originator, and probably some people might claim its history goes back a long way, probably. But certainly for Bromley by Bow, it started in this dilapidated church in the mid-1980s with a young priest arriving. And it sort of responded to our almost sort of intuitive understanding of the needs of our community. This deprived church became a bit of a community hub under Andrew Mawson, now Lord Mawson, famous in the world of community development and community regeneration and social enterprise, of course. And we then became, we basically petitioned that we wanted to establish general practice at Bromley by Bow in that black and white photograph, essentially a small community hub. That's the back of the church there. And faced huge opposition from the NHS, actually. The NHS had never heard of small community charities building health centres before, GP practices. It was obviously something that only GPs or the NHS did, not small community charities like ourselves. In the end, Andrew got Brian Mulwiney, the Minister for Health, down to Bromley by Bow, and he instructed the strategic health authorities to try and to talk to us, whereas they'd been trying to avoid desperately from talking to us. And we got the green light to build a GP practice and a healthy living centre. We became the first healthy living centre in the UK. So a fairly substantial community anchor charity, community centre, with about 50 staff delivering community services and doing community development, installing general practice on its premises 15 years into our journey. We found Sir Sam Everington and Dr. Julia Davis, who came and set up general practice. We built a new health centre, and we took over that scrappy park and we turned it into that beautiful 3-acre sort of health campus that looks like this. So that's the array of services we have at Bromley by Bow. It would be a mistake to think that social prescribing is the only thing that unites the general practice and the community centre. This is really about an integrated model, and it's about sort of about 80, 90 staff from general practice and the community centre working together on site. But social prescribing is hugely important within that. What's really interesting, of course, we've become very familiar with these sort of diagrams now that show the social determinants of health. And you know, so 40% is pure socioeconomics, and then we mythologically say that 30% is down to free choice. It's to do with health behaviours, but of course they are entirely socioeconomically driven as well. And then if you think about housing, well, that's pretty socioeconomically driven as well. So you've got about 70 or 80% of that package is socioeconomically driven, and about 20% is down to the good work of the NHS, the £180 billion a year that we spend on clinical health services. By the way, of that £180 billion a year, we spend 96.3% of it treating people who are already diagnosed as ill, and we spend about 3.7% of that money on prevention, which is largely immunisation and screening programmes. So there's very, very little prevention in the NHS at all, actually. But if you go back a step, you will see that Bromley by Bow's services very much mirror what you see there. So, you know, this is a very logical approach to this, with social prescribing, of course, being very important. It got us to rewrite the concept of primary, secondary, and tertiary care. That really responds to this understanding. So that's, you know, this is trying to use an evidence-informed approach to trying to define what we do. This is 80% of the health outcomes, and that's the 20% up the top. This is a basic standard model of social prescribing. You'll probably be all familiar with this. Martin Marshall, by the way, when he was chair of the Royal College of General Practitioners, said that social prescribing was the biggest cultural change in the NHS for many decades. I would argue it's actually the biggest cultural change in the NHS since 1948. If we understand this correctly now, we have 4,000 members of staff within the NHS who are trying to improve people's social determinants of health. They're called the social prescribing link workers. We have about 1.1 million staff in the NHS who are delivering largely clinical care to people. So we've understood the 20/80 ratio. We haven't quite got that right in terms of staffing yet, but that's sort of really interesting to think about. But the really important stuff is at the top, the valued collaborative relationships within general practice and everybody else, and this really healthy, vibrant voluntary sector on which to refer onto. I think these are some of the areas that we have got to develop further. If you want to understand the life of a social prescribing link worker, this is based on 2 focus groups that Marcello and Caroline did at UEL about 6 or 7 years ago now. But that will explain why a social prescribing link worker carries out such a complicated role. That is the role of the social prescribing link worker. Very, very complex indeed. It is not just about seeing patients in consulting rooms in GP practices. So I thought I'd put this slide up. Where have we come from? Who are we? And where are we going? This is from a detail from a Gauguin painting. So we've come from community development, and thank you, Charlotte, for mentioning that. So this all comes out of community development. Got adopted by the NHS, big bang, fantastic. The commitment to 4,500 link workers' salaries, going big at scale. We now got 4,000 link workers spread across 1,250 primary care networks. So that's fantastic. I wanted to talk about where we've got to go, because social prescribing has got off to a fantastic start. This is a wonderful moment to do a bit of a stock take, but there's much work still to do. We definitely need ICSs to really adopt a vision for social prescribing within their areas and adopt to not just funding the social prescribing link workers, but also starting to think about the services to which people are being referred onto. The last 18 months has marked a stalling in the increased number of social prescribing link workers. It's not going up, it's plateaued. The NHS is now committed to 9,000 by March 2037. So we need to keep the impetus growing to increase the volume of social prescribing link workers. And we need to see how they are much more part of an ecosystem. I think integrated neighbourhoods provide us, a wonderful opportunity there. We need to spread good practices. I mean, I've just been teaching some social prescribing link workers this morning across England. There's wonderful practice around the country, but there are also some real challenges as well. So we need to spread good practice. We need to ensure that there are good standards in social prescribing. I've heard link workers distressingly telling me that their consultation times have been chopped down to 20 minutes, for example. We need to push that back up to 45 minutes or an hour and multiple sessions. We need genuine social prescribing, not a kind of signposting service. We need training and development. We need greater integration in the clinical, which is, you might find odd for me to say that, but social prescribing needs to be absolutely rooted in the clinical. It also needs to be rooted in the community, at both ends of the telescope, really. And how long do I have to go? 3 minutes. Okay, right. This is our website. It's both got, our GPs now have 4 health centres, but it has all our non-clinical offer on the same website that our patients are trying to book their consultations or do e-consult on, which I think is interesting. We've now introduced in all long-term condition plans at Bromley by Bow the asking of questions about social determinants of health. It's written into the long-term condition plan. It's SNOMED coded. So we've got 50,000 patients, 9,000 with a long-term condition. We've already asked 4,500 of them those questions. That's led to 16% of that 4,500 being referred to social prescribing. So this is proactive. This is like a clinical, it's a biopsychosocial pathway, if you like, looking at the clinical and the non-clinical for patients with long-term health conditions. This is a youth club with social prescribing in it, and 3 of our GPs go into that youth club and do consultations with the young people in the youth club. That's really, really interesting because those young people don't want to go to the GP where their parents or their parents' friends are registered, of course. Why would they? This is a self-help group for parents with had very high consultation rates with children with very young, parents with very young children. This is about running a 12-session course in health literacy about parents. So lots of parents socially prescribed into this. This creates social capital in the community. Parents with knowledge and capability and know-how about young children's health who then become support for their neighbours, for example. So we need to think of social prescribing as part of a community development process as well. And this is the last slide you'll be relieved to hear, Monica. So we all know about primary care networks. We've all started to hear Claire Fuller's talk about integrated neighbourhoods. This is our vision for an integrated neighbourhood. The yellow dots are GP practices. We need not just social prescribing link workers, but we need navigator and connector roles in the community doing a light touch version of social prescribing. There's no reason why housing associations, children's centres, community centres couldn't all employ a light touch version of the social prescribing link worker in them, or school parent liaison officers, for example. So this is bringing together. The yellow dots do the 20%, as we already know. Then it's bringing them together with the organisations that do the 80% in our neighbourhood and saying, let's create one single network. Let's call it a health creation network because it's going to be based on asset-based approaches and place-based approaches. So this is very much seeing our community as our greatest asset. You know, we have to really move away from just this idea of, as somebody said, of passive recipients of services to active participants. Because, you know, we could probably double the NHS budget tomorrow and there still wouldn't be enough money if we only go down the biomedical route. We have to harness the power of our communities. So this is taking the concept of primary care networks, blending it with the stuff that the Health Creation Alliance talk about and the stuff that Claire Fuller talks about, integrated neighbourhoods, and creating what I would call a health creation network on a primary care network footprint, rather, so that it footprints on primary care networks. And then you start to think, what does social prescribing do for all of that together? Not just as some sort of linear pathway from GP consulting room to link worker to service. This becomes part of a much more circular ecosystem. So that's what I'd like to leave you with.
Thank you, Dan, and thank you for sticking to time. I just love hearing about the work of Bromley by Bow. It's kind of simultaneously reflective and visionary all at the same time, and some really great nuggets to take away there. But what does this mean for the person? There are people that receive this thing that we're calling social prescribing day in, day out through our healthcare system. And we're going to hear a little bit more about the difference that it's made in Deb's life. So I'd like to introduce you to Deb's Teal.
I'm going to start by saying something quite radical. And I want you to take this out of this room with you. Our heads are connected to our bodies. So why does the NHS think we need a mental health system and a physical health system? Because if anybody's involved in the physical health system, they know the departments within that don't even speak to each other. So how the heck are they going to speak to another organisation who don't work with them? And I think it's really important that we understand that and we listen to that, because I don't know about you, but I can't leave my head in one hospital and my body in another. If anybody else can, I'd love to know how you do that. And the reason I say this is because I've been in the service from the age of 8. And back in the good old days, and I know I only look 21, but I am a little bit older. Back in the good old days, you saw a GP in a spare room of his house. But he knew everything about you. He knew everything about your family, and he treated you as such. Now, at the age of 8, I was given the label bad nerves, because back in those good old days, you had 2 things for mental health, and it was bad nerves or a breakdown. And I was in the bad nerves category. So that was the start of me being in what then became the mental health system. And when you're in that mental health system, you have to be a participant. You have to conform to what they say, or your treatment is affected. And I often describe my journey as being a passenger in a car of my own life. Everybody else had the driving seat, whether that was my parents, whether it was the system, whether it was my ex-husband. I was never given the skills or the knowledge to drive my own car. I was always a passenger. I wasn't even asked where I wanted to go. I had to go wherever they took me. And I was used to that. I didn't know any different. So to me, that was how life was. And then in 2010, I had an absolutely terrible year. I lost my mum, and then another event happened, which just absolutely floored me. It floored the whole family. And I went to the psychiatrist that I was under, and I begged him for electric shock treatment because I just wanted to feel normal. And he said to me, "It's not suitable for you, it's not right." And then he said, "You're always going to be ill, you're always going to be medicated, and you will never work again." I was on 21 tablets a day at that point. I was often bedbound, my children were my carers, and I'd been medically retired because of my mental health some 14 years earlier. So I never questioned what he said. He was the expert. He was giving me the answers to my problem. And I didn't want to live with that problem. I'd had enough. I felt my daughters deserved freedom. I felt if I took myself out of the situation, they would finally get a life that they could live. So I took an overdose. And I woke up in hospital, absolutely livid that I'd failed. And I was in bed opposite a lady who was dying of cancer. And she had a wonderful palliative care plan in place, which by rights she should. I felt I'd been given a terminal life sentence, but I didn't get the same care. The nurses, the lady who was dying of cancer, she was really nasty to me, and nobody batted an eyelid. And the nurses were saying really helpful things like I was attention seeking, and I'd brought it all on myself, and the bed should be for somebody who deserves it, who really deserves it. And I'm agreeing with those nurses. That was how I'd been brought up, to realise that I was the problem, to realise that I was the issue. So the plan was to pretend I was okay, to get out, and then to do it right next time, to take more tablets before I passed out. Part of being discharged was that I had to go to psychology. Great, I already felt a burden, and here you are giving me more services to feel more of a burden in. But I went along because that was part of me getting out of there. And whilst I was sat waiting for that assessment, I saw a leaflet, Art for Wellbeing. So you can see artwork flying up there. This is all my artwork. Never done art before. My kids used to take the mickey out of me when we played Quick on the Draw, but something made me pick that leaflet up. I took it in when I went for this assessment, and he said, I don't know a great deal about it, but give them a ring anyway. I rang them. The art class was 5 minutes from my house. It was a taster session, so there was no pressure if I didn't want to do it. So my friend quite rightly dropped me off and then drove off and left me there, so I'm like, thanks for that. But that's the day my life changed. That's the day something came alive within me. And I started drawing. And for anybody that says I can't draw, I still can't draw. I paint now and I like painting. But it's the ethos. If you can make a mark on paper, you can make art. And I started to draw, and it just gave me something different. It gave me a bit of life that actually I can do something here. Something is worth keep going for. So initially, I started to think, that psychiatrist gave up on me when I was at crisis. He literally threw me over the edge of the cliff. I need to change that. I need to give service users, which is a terminology for people in mental health services, I need to give them hope. I need to give them some aspiration, because if they're saying it to me, you can bet your bottom dollar he's saying it to other people. So I started doing talks to people who were coming to this art class. I ended up getting a waiting list of people wanting to come and hear me talk, and all I was doing was saying, the answers are in us. We just need help unlocking those answers. And after a while, I was asked if I would do a talk for the professionals. I'm like, what on earth can I say to them? They're the experts, and they're asking me to do a talk to them. But I went, and I started the session, and I realised 3 things. Because I'd started doing the talks initially to give service users hope and aspiration. But I realised that staff, they were reading about my condition from a book, which we've got to start somewhere, haven't we? They were only ever seeing it at crisis point, because you're not in services unless you're at crisis. And the third and most important thing that I learned was that staff needed hope as well. So I started to change tack and started to think I need to work with staff to give them the hope and aspirations that things can get better, things can change, things can improve. And you'll see I've been to a few places there. I remember when I was asked to go to Buckingham Palace, and I just, because I'd done one of my talks, and this really well-dressed gentleman came up and he says, oh, I'm really inspired by what you say. He says, how would you like tea with the Queen? And I'm like, oh, no, thanks, I don't drink it. And he looked at me and he said, that's not the right protocol. I don't drink tea. And I just thought, because I've had 40-odd years in the service, he was taking the mickey out of me. And I was used to people doing that to me. But then when he said, that's not the right protocol, I thought, oh, actually, he might be genuine here. So I did have apple juice, and I met the original Queen before she passed away. And even as I was stood in the queue waiting to go in, I expected somebody to tap me on the shoulder and say, who do you think you are? Get back, this isn't for you. This isn't what you do, because it's not my life. That's not who I am, that's not what's happened to me. So I want to tell you now where I am. I've been off all medication now for nearly 13 years now. I've been out of services for 9, and up until last year I worked in the same NHS trust as the expert who told me I'd never work again for, which was always interesting on the corridors, because, you know, there he'd given me this, you can't do this, you can't do that, and here I was proving him totally wrong. He did become a real advocate of what creativity and social prescribing, and he did change his tack and start looking at recovery. And I think we need to start working in sort of not looking at the deficit base, looking at the evidence base, looking at things that, you know, we can do things about, things that we are good at rather than what we're not good at. And people often say to me, what was it about art that worked? Art trapped me holistically. It saw me holistically. It didn't put my head in that hospital and my body in that hospital. It was the whole picture. It was something that was unique to me, although it wasn't, but it felt it. And that art class that I did, it sort of, it focused on my wellness rather than my illness, which changed the whole tack of how I saw things, how I looked at things. So I mean, when we're talking about the determinants of health and 20% is actual health, we need to look at the other 80%. We can't just see people as a linear process. We've got to look at the bigger picture. And that's what social prescribing does. That's what the link workers do. And I'll have to be honest, because I've been involved in social prescribing sort of from the beginning, I was really against link workers. I'm like, no, we can't have link workers, they'll take over. Because that's all I'd had in my life, is people taking over. And I didn't want them to take over. And I'm like, no, and I was all against it. And everybody assured me they'll be fine, you know, it'd be really helpful. And then as I've listened and as I've watched, we've got some fantastic link workers out there who do treat people holistically, who do look at the bigger picture, who do address the social determinants of health. I'm just going to go back this. I know it looks a really dark painting, but I call this my silver lining, because I've still got the rough turbulency in my life. I've still got them big black clouds. Social prescribing hasn't magicked everything away, but it's allowed me to live with those conditions. It's allowed me to cope with those conditions. And it was only years after I painted this painting, and somebody said to me, that's just you. It's like a phoenix rising from the ashes. And I'm like, oh yeah, I'd never seen it before. I'd just painted it. So it was by fluke that this. But it's really important that we don't forget that glimmer of hope. Wherever we are in the system, whoever we are, whether we're in services, out of it, working, we need to focus on that hope, that glimmer. And that's what social prescribing did for me. It gave me a life worth living. It gave me the ability to stand here rather than be that gibbering wreck at home that my children had to look after. So for me, sort of just going back to finances, 1 year, the art class that I did was about just short of 2 years. It cost less than 1 year's medication alone. They did a social return on investment on my journey. They're saving £33,000 a year. I'm just one person. Now, and I know I've had this conversation with Michael Marmot, I don't care about the money. Yes, it's nice the NHS is saving money. I care about my life. I care about the life my children have now. That's what matters to me, is that I've got something. And that's why I do what I do, to give that back, to tell people there's hope out there. We've got to keep giving people hope. So on that note, thank you very much for listening.
I'm always moved hearing Debs speak. She's just absolutely fantastic. I'm not going to even try and summarise because I would just not give it justice, but just to say thank you, Debs, for sharing your story and being so open with us today, and that really powerful reminder of focusing on what matters to that person and not on what's wrong, but what's strong, I think is a really, really powerful message. We've got about 10 minutes for questions to the panel. We've got a couple of microphones that are floating around the room. Thank you to Angie and Alexis for that. So does anybody have any questions for the panel? Gentleman at the back first of all, and then we'll come down here.
Can you hear me?
Yes.
I don't know if I can confess after all that I'm a psychiatrist. Congratulations to all of you, and special thanks to Debs for both her words but also your paintings. They're lovely. Thank you very much. I have a challenge, a cheeky question and a challenging question for Dan, I think that is. I noticed that Kingsley Hall is on your premises, and that has a very special place in the history of psychiatry, in that it was an anti-psychiatric treatment center in the 70s. I wonder whether you have any relation with that. That's the cheeky question. The most challenging one was that you talked about we are producing, or Ahmad, I think, did I get your name right? We are producing more illness. And one of the things you don't do is challenge the economic models we have, which are part of what is, in my opinion at least, producing the illness. So in that sense, I think you do marvelous work, but I wonder whether you are the people that could do even more work.
So just to answer the question about Kingsley Hall, no, it has no relationship to Bromley by Bow Centre at all, although it is in the neighbouring, it neighbours us as a community centre, but it's got no relationship whatsoever. Just to take your point, I mean, what you're really, alluding to are both, the huge biomedical models of health that were established after the Second World War that went down a very curative pathway, i.e., and we still spend over 96% of the NHS budget on treating people who are already diagnosed or busy diagnosing them. So that's one thing. And I think the other thing, and so that really needs to change. If we believe in prevention, and we believe in going upstream, and we believe in working with communities in a very different way to the way we do today as co-producers, that needs to change enormously. But I think the other criticism of social prescribing, I don't think it's a criticism of social prescribing so much, is that it doesn't really address the fundamental social determinants of health and the structural inequalities in our society. I mean, just to say, by the way, the life expectancy gap between the most deprived and the most affluent Londoners doubled between 2002 and 2017. It doubled to 18 years. So the wealthiest in London live 18, that's not healthy life expectancy, that's life expectancy, live 18 years longer than the poorest in London. It doesn't, but it certainly shines a spotlight on it. 50% of clients going through social prescribing in London are also onwardly referred to social welfare benefits advice for fuel poverty, food poverty, housing, debt, and welfare benefits claims. So 50% of those going through social prescribing are at that end of the sort of socio-economics. As you probably know, London has 1 million Londoners on the housing waiting list. 1 in 10 Londoners is on the housing waiting list. I think social prescribing helps to shine a spotlight on that. It doesn't change national policy. Obviously, that's something for government.
Thanks, Dan. Mark, did you want to comment on that at all?
Is it on? Yeah. You can hear. Yeah, so I'll just say very quickly, absolutely, I agree that there are financial incentives and drivers for any clinical worker to actually diagnose a patient. There is narratives out there on how we can actually combat that. Dr. John Lowner talking about dilemmas and how to actually have conversations with patients to just introduce them into the decision of a diagnosis, to be transparent on the margins of errors, of margins of uncertainty. And I think once we change the language of healthcare, and social prescribing is actually partly doing that and inviting that sort of complexity, we can remove the burden of overdiagnosis, unnecessary overprescribing as well. But lastly, just to say, this isn't to stigmatize equally necessary and valuable medicine. Medicine is important. It has its place and purpose in our clinical practice, but the graphs do show it's unequivocal. We do have a problem with our prescribing culture.
Debs is just going to come in, and then we'll go to this gentleman, and then we're going to have to move on, I'm afraid, because we're coming to the end of time.
I want to say we work in a deficit base. If you need any help, whether that's financial or social, you have to have a diagnosis. So while we're working in the deficit base, we're not ever going to win it.
Thank you, Debs.
Hi, thank you all for some really interesting talks. I don't know much about social prescribing. I didn't know much prior to today, but I've often wondered about it, and something that's come out, and I wonder if I'm just missing the point or partly missing the point. It is, if I understand correctly, a lot of this is about, or some of this at least, is about mental health diagnoses on the margins of, you know, whether it's a treatable mental illness or actually whether it's something more of a social, you know, you talked about food insecurity, poverty, housing, and whether there is also some element of social atomization, whether this is people who are often disconnected, sad, but framing it as a mental illness is actually very unhelpful, and reframing it as something about social integration is really what this what social prescribing is, and I just wanted to understand your perspective on that.
Can I just come in? Because I think we've got to be mindful that your mental health impacts your physical health, and your physical health impacts your mental health, or it can do. You know, so that's why we must look holistically at people. That's why we must start looking at the bigger picture. And the beauty of social prescribing, especially in the mental health system, is that it connects you back into the community. One of the things we do when we've got mental health issues, a lot of us, is we hide away. We don't want people to be infected by our sadness. We don't want people to see how ill we are. But this gets us out there. And if we can focus on that wellness rather than that illness, that's a start.
But also, I think to say that, you know, you're talking about understanding the drivers of the health, how things present in general practice, say, but actually are driven by social need. Social isolation and loneliness is a massive driver of consultations and ill health. Equally, of course, is debt and housing and welfare benefits as well. We know that it's fairly conclusively established that 20% of consultations that happen in general practice every day are driven by a social need. And of course, quite a lot of those needs can then be causal around low-level mental health problems, or vice versa. Mental health problems can cause, for example, financial issues and debt issues and irrational expenditure patterns. So it can work both ways in a sense. The medical can feed into the social and vice versa. But if we only then treat it with pills, we are completely missing the point. And I can't remember what that percentage is, but I think the increase in antidepressant prescribing in Britain is about 400% increase. So I think it's 1 in 4 adults in Britain is on antidepressants or something like that. I mean, the problem therefore isn't about treating antidepressants with pills. The problem's asking about what is the society that's generating this pandemic of depression and loneliness and social isolation.
Sorry to interrupt, but I guess the question was, are we conceptualizing a lot of things as depression that actually may not be depression, that aren't going to respond to antidepressants, that need an approach of this sort? And that's what I was hearing in what you were saying.
And I think as well, we're sort of, with the cost of living and poverty, we're making it come into the NHS. It doesn't have to. If we can fix that external to the NHS, but because people don't have the money, they're coming in, whether that's through a mental issue or a physical issue.
I think we're up to time. We are all willing to continue this conversation, I believe, sort of today and beyond. So if there's any other questions, please do feel free to email NASP, and we might be able to come up with a bit of a sort of FAQ to support the answers to some of those questions, because I appreciate this is a rather large topic and we're not going to get to everything today. But just a thank you again to Joelle, Hamad, Dan and Debs for their contributions to our first panel today. I'd like to give them a round of applause. So the next session is all around social prescribing across the life course, and I'm going to bring us back, you'll be no surprise, to that global definition that I talked about earlier, which really highlighted that function that social prescribing provides. The power of social prescribing enables us to meet the needs of people where they are in the community, and that sometimes requires there to be slight nuance when we're being more proactive in our approach for social prescribing. So we're starting to see different projects that are springing up that are supporting people not just with conditions but with specific age groups, which we heard a little bit about the evidence before. So I'd like to introduce our first speaker, who is going to be Tracy, and she's going to be talking to us a little bit more around the children and young people social prescribing landscape. Thanks, Tracy.
Afternoon, everybody. I'm going to give you just a note of caution. I work at the National Academy for Social Prescribing, and I'm actually the National Lead for Physical Activity, and I'm here today to talk to you about children and young people. But that doesn't mean, and I've been looking at this for the last, we've been looking quite detailed about the children and young people's landscape around social prescribing, and we're going to talk to you today about how that we're hoping to grow that, but give you a bit of an idea into what's happening at the moment and kind of where there's some real opportunities along the way. So some people might say, oh, just got the clicker, there we go. Why children and young people social prescribing? Well, actually the evidence starts to show us that we know already that there's work going on around early interventions, particularly around children and young people on, unfortunately, on waiting lists around kind of child and adolescent mental health services. There's a lot of work going on around that, and I'm going to come back full circle to that at the end, say what we're thinking with our journey. We also know that obviously social prescribing can really help with self-esteem and things like art, from you've just heard. It can be really, really beneficial, particularly around children and young people, physical activity, all manner of activities. Really connecting young people into their community is really important. But obviously also looking at things around loneliness. And what we do know is that many children and young people that are referred to children and young people's services around social prescribing, one of the main reasons for that is loneliness, which is quite kind of disheartening, really, to think you've got children and young people out there in communities that are feeling very lonely and very isolated. So when we think of loneliness, we sometimes think around older people, but it's very prevalent around in young people. And we know that social prescribing can be very, very beneficial. It also helps build some of those links with those gaps that's kind of out there in communities, linking between services. We're finding that out there as well, and obviously linking into those wider determinants of health. But what's the need? Well, when you think about children and young people, 1 in 5 children and young people in England have a probable mental health disorder by 2023. That's risen dramatically in the last 5 years. So when we think about Hamad and what he was saying around health, we're on a trajectory, particularly around mental health in children and young people, that is very, very worrying. The average wait time for children and young people that are looking for child and adolescent mental health services is on average around 21 weeks. In some areas of the country, when I've been talking to different ICBs, it can be up to 2 years. So it's a long time that children can potentially waiting. So think of Debs when she was saying she was 8, going into those services, that it would be a very long time for it to go through that. How can we help and work differently? And we're starting to look at that with social prescribing. We also know that the most vulnerable children and young people in our most vulnerable communities actually really do struggle to actually link in to any form of mental health service. And yet that is where mental health is most prevalent, around those groups. So how do we link into that? We also know through recent research from Cambridge University, that young people particularly who have got a social worker attached to their family are 3 times less likely to even get accepted as a CAMHS referral. So when we start to think about our children and young people and their mental health, particularly as it's most prevalent in terms of at the moment that's in society, and we hear it on the headlines all the time, how do we start to change that? How do we start to think differently? We also know that children and young people feel judged, not only by their peers, and they feel embarrassed to talk around their mental health and their mental well-being, and Save the Children have done a detailed piece of work around this. And then obviously parents feel that because of those waits, their children are left in crisis, and actually see them actually going further and further in a more downward spiral. But we also know that when you think about what enables good health and good mental health, they're the 5 pillars. So that's things like good nutrition, being able to sleep, mindfulness, exercise, and most importantly, connectedness. And yet, when you look at the research that's just come out recently from NHS England, from their Children and Young People's report, we know that of those children with a probable mental health disorder, most of them have not exercised for 7 days. 34% have not been out and accessed green space. And 80% have not taken part in any group or clubs. So think of loneliness, think of isolation, and you can kind of see what's going on there in terms of children and young people. So there is a real need to really change this trajectory about how we support children and young people, predominantly going through the health system and thinking how can we work with them better to connect into their community and also connect into their health system in the most effective way, and most importantly, what matters to them. So the impact on children and young people, social prescribing, is mixed. At the moment, if you ask and looked at, whereas Joelle said, there was probably 4 studies that used the word social prescribing. Yet if I look at it from my background and go, actually, if I look at the impact of physical activity around mental health and well-being, or art activity, there is a plethora of evidence out there. It's how we categorise it. So social prescribing and the social prescribing link worker role is relatively new, in terms of we've had the investment from the NHS, and how is that using that investment for children and young people? Well, at the moment, it's very sporadic, and in terms of the
kind of R's role funded link worker, there's not that many across the country. There's some coming up, but it's not everywhere. It's a bit of a lottery about how you would find that. But what we do know is obviously due to connectedness, due to physical activity, due to access to green space, all of that can be really, really beneficial from your health and well-being. And there is more and more activities and more programs that are coming out there and starting to do that and enable that for children and young people. We know there's the evidence that comes up. There is an improvement from those around it improves young people's health and development. It does have a positive impact on mental health and their cognitive performance, which obviously links into schools and staying into school and there's lots of work around children and young people that are not in education and training as well that social prescribing is starting to pick up on. So what do we know? We know we've got a problem. We know we've got some evidence to start showing that there is real benefits for around children and young people, and we know we've got a system where currently within the NHS it's an all-age model around social prescribing, and yet some areas are actually starting to look at how they work more with children and young people. So it's not the norm. It's not like the adult model. It's very different, and there's lots where we need to understand it more, and there is lots of areas where potential growth could be. And more people are starting to turn and start to think about how we do that. At the moment, for social prescribing and children and young people, we do know when it comes to that, all in case of, well, who's going to fund it, we do know that it needs a much more holistic approach. We do know it is about much more co-producing, most importantly, with children and young people, but also with the local authority, with the health system, with youth services, with schools, with colleges, to really understand holistically the lives of those children and young people and look at how they can all come together and do a co-shared investment model around children and young people. And most importantly, as Dan said in Bromley by Bow, it's not about young people going to GP practices. It's also thinking about how we can go to them and work with them in their communities and what matters to them. Because what we do know is when children and young people do turn up in a GP practice, in some cases, not all, but in some cases, they turn up in crisis. And then we're into that whole system. So how can we kind of change that? But funding is also driven by local authority, and the best models that we see across the country are where they are actually all brought together and work in a shared investment model, looking at what matters to those communities and what matters to those young people. So there is some real key learning, is that if you think around social prescribing and the kind of R's adult model, it's so different for children and young people. It is about really thinking about how you can work much more closely together and going to where young people are in those communities, thinking about other organisations, and also because of safeguarding and kind of risk management, it's also sometimes beneficial, which we have seen in certain areas where link workers particularly are then housed within a youth organisation rather than working the other way around. The need for a multi-agency approach. We don't want young people to get to crisis, so how do we work with organisations in those communities? I loved Dan's neighbourhood model, and it's something we're thinking around children and young people, that can actually identify when children and young people need that little bit of support. Really looking at how children and young people social prescribing can move to more of a preventative model rather than we need it as a treatment model. Thinking about how we can connect them into their community, connect them to activities, connect them to things that matter to them. So it's really about how we can enable that and think about those ways of working, and where that's working well, it's working extremely well. So we have seen that in certain areas of the country. But it's obviously about that co-production and involvement with children and young people. Recently, we've just run a panel for children and young people and asked them, what do you think about social prescribing? And they absolutely detest the words. They don't like social prescribing at all. They're like, what is that? It sounds like I'm going to have another prescription. They want something much cooler and much trendier than that. And they want to be involved in it. And that's the most interesting thing. They do really want to be involved. And they realise they need to be connected to their communities. But they have an enormous amount of pressure on their lives that's stopping them from doing that. So we need to scrap the word children and young people social prescribing and come up with something cool with them, I think, for that. There's definitely the need for that kind of more integrated and working across services, really thinking about, particularly schools. We've seen a lot of work that's coming out of schools and how they kind of interlink together. So it's quite a different landscape in terms of what's happened with children and young people. It is about going to them. It is about working alongside a multitude of partners and creating a really holistic provision of which they feel that they can own and shape themselves. So there's so many different pathways to it. What we do know with children and young people is that we're seeing more and more of where actually there's I would call early intervention kind of programs, arts programs, sports programs, arts and sports, green programs, youth programs, all coming together and actually linking to schools and picking children and young people up when they're just on the kind of primary prevention side, preventing, or there's a sign, there's just a little sign to say actually that young person might be struggling to cope. They might just not be turning up for school as regular. How can the school work and then look into an early intervention programme? That then within that there is a social prescribing plan, that then within that they kind of have that what matters conversation and link them into other activities in their community. When we look at ours roles currently across England around children and young people, they're predominantly working with 10 to 19-year-olds, predominance, and that's more that higher end 15 to 19 within there. So those ones that are going into the GP practice, that are linking any of those ways, if the ours roles are in those practices, which the majority which we found from our survey are, that's who they're picking up. And we do know that across all, both early intervention and into a link worker, the top referrers are GPs, schools, a top, and then obviously other areas around mental health service are linking young people into services. The top reasons for referrals for social prescribing for children is mental health. That's the top one. Then followed very quickly by loneliness, which the two can interact, and very quickly by NEAT, not in education and training. And again, all of those factors all interplay with one another, so it's not kind of one thing. Children and young people themselves, what they're asking to be referred into are youth services, fun activities, physical activity, arts, culture. They're the types of things that they're really enjoying and wanting to do and actually having a real impact on their lives, which I'll come on to. But we also know the social prescriptions, so that great physical activity programme that's doing things out in nature and also connecting with a youth worker involved, they also themselves need some help and support to ensure that they're offering really high quality provision for children and young people to really support them. Across England, well, across the country really, there is hundreds of different programmes. There's the WAVE project, for this is an example, where they, for young people, have got counsellors offering surf therapy. And this happens on all our coastal communities all around England for children and young people. Or then you've got in many community football trusts across the country, programmes such as Winning Minds, that actually does do detailed evaluation and where there's 89% uplift in young people's mental well-being. So there is all sorts. There are art programmes, there are music programmes, there are all sorts of programmes. The most interesting thing I find is actually when I talk to the providers of these programmes and I say to them, how connected are you to your local health system? They'll all go, oh, Tracy, that's really difficult. I don't know how to connect. But they're all funded and working in ways, but there's not actually sometimes that connectivity within those systems. And how can we make that better? And that is something that we're really, really trying to look at and trying to develop further. So we feel it's time for action. And it's time, and I feel that, yes, I'm going to use a sporting analogy because of my background, that yes, we're on the kind of the start line. We've been doing something like an appreciative inquiry to understand really what's happening around children and young people's social prescribing across particularly England, but we've also looked at Wales and Scotland. And we've tended to find that it's very sporadic. There is real, absolute opportunity for growth around the area. And at the same time, as we were thinking this, also, it was great to see that the House of Commons was thinking the same of us as well. And they said through a Prevention in Health and Social Care report that they also wanted to look at how social prescribing for young people could be increased across a number of referral routes. And that could be schools, education, community settings. So really thinking that whole holistic model linked back to the kind of the definition, I couldn't think what the word was then, the definition of social prescribing and how could we do that. So we've taken that and we've brought together a group of organisations, individuals from NHS England, Department for Health. We've spoken to lots of organisations to think about what did we need to do around children and young people. And we fell upon that we want to develop a joint vision for children and young people social prescribing with a particular focus on mental health that shapes national policy and practice. And that's in the process of what we're doing at the moment. We're looking at that, we're understanding that to think how can we do this and what is needed to build better connectivity that really can impact on children and young people's lives. We were very thankful for the Limbury Trust and the Sam West Foundation who funded this piece of work and enabled us to kind of drive this forward. So we've now got a joint advisory group with a number of different colleagues across a plethora of different sectors and lots of different organisations on there to actually all coming together to think how can we do this much better and what can we drive forward. We've started a big conversation. We've had the advisory group, as we've said. We've met with, I think now over 40 different national organisations, such as Save the Children, such as the Mental Health Coalition, Youth Action, you name it, we've spoken to them, and a number of different government departments from the Department for Education, Health, etc., thinking about how can we build a better connected system for children and young people. We're continually on that now, and we're looking, and we've had at our international conference, we had a conversation about it. And this is what people said. People started saying to us, yes, we feel it is very, very important to think about children and young people, that education does need to play a really key role in it. And we're obviously looking currently at the government's manifesto talking about mental health workers in schools. Could they actually also offer a social prescription to children and young people early on? Looking at the Young Futures hubs that the government are talking about more and more, as we see Social Prescribing in London has done a brilliant piece of work around children and young people and violence and gang membership. So actually thinking, how do we embed social prescribing into the fabric of children's services to really enable them to be connected, so that hopefully one day 80% of children and young people won't feel not connected to a group or a club in their community, won't be not going out, 34% won't be going out into green space, and definitely for me, 26% will be moving that little bit more, because it is so important to enable that to innate people's lives and to be physically active. Because if we can pick people up younger in a more preventative model, surely it's better to switch the tap off, which comes back to, there's lots of research going on around waiting well. And I was quite bold the other day. Charlotte saw me in a meeting with NHS England, and I said to them, why are we looking at services around waiting well? Why are we not looking at services where children don't have to wait, where they'll go through that door and automatically be connected to activities in their places? Surely we want to eradicate waiting well, and we want to get to a place where hopefully not as many children would need so much support, but when they are walking through that door, they're walking through to a holistic service that can support them and build them around their needs, not thinking they're on a waiting list to wait for something that we do know between 26% and 75% around talking therapies, unfortunately, do not take up. So how can we change that? So we've been having that big conversation. We're on a journey. There is some big hills along the way and some valleys and some tracks that we're going through, but we really are looking at how we can build a much more connected system around children and young people. And anybody's got any thoughts around that, definitely come and talk to me today. And hopefully I've done it on time. Just about. There we go. Lovely. Thank you very much.
Oh gosh, have I? Hi everyone, I'm Nurjahan Ali Arobi. So again, like similar colleagues, I work at National Academy for Social Prescribing, and today I'll be focusing on older people, and I have two colleagues with me who are going to speak after me. So to start off with, I wanted to give everyone a sort of a background in the policy and research base for older people and healthy aging. So the World Health Organization is really focused on a decade of healthy aging, has set the scene for NHS organizations across the country and for people both working within the community and other sectors to focus on how people across England and the UK can focus on aging well and healthy aging. Alongside of that, the Office of Health Improvement and Disparities focused on healthy ageing and responded to World Health Organization's challenge, and there's lots of work happening across the country. In terms of focusing on older people and looking at things from a biomedical model, NHS England is focused on the frailty strategy, which was launched earlier on this year. And one of the things that I'll be focusing on today is how we're trying to support frailty for older people through social prescribing. But as mentioned, I also wanted to focus a bit on research and what's kind of the current thinking about healthy ageing across the country. So the Health Foundation is really focused on the fact that we will have increased levels of illness. So this is something that Hamad focused on. So I'm not going to go into the details. He really highlighted very lucidly the kind of direction that we're travelling in. So how can we support people to age well and focus on their strengths, their assets that will enable them to maintain their current level of health or actually improve it. And that is also about maintaining mental and social well-being as well as their physical well-being. The King's College London is really focused on the ageing process. There's a lot of research that they've done about actually how can social prescribing, how can other forms of intervention support healthy ageing. Just on the other side of the slide there's a little bit of policy history about social prescribing, which covers all ages really, but I wanted to focus on the fact that the last bullet point, the Directed Enhanced Service, so the DES, this year was really focusing on providing access to social prescribing. It's not necessarily the social prescribing link worker role, but to social prescribing. And that can be both within GP practices, within primary care networks, but also within the community. And we'll be focusing a little bit on the community today. And just to top off the sort of focus on policy and research and sort of the think tank around healthy ageing, I wanted to focus on or highlight to you the UK Health Research and Innovation work that they've done over the last 5 years. This culminated in an event this year focusing on how different NHS organisations, different community organisations worked with the private sector to add life to years. So we have older people who are currently in the space of no long-term conditions, people with one or more long-term conditions, all of whom are being supported by community or private sector organisations, so that whatever their age is, whatever their physical health condition is or their mental health condition, we're adding life to those years so that they are actually having a better life situation. Also, in terms of looking at working to support older people from both a biomedical model and a psychosocial model, in Bradford there's a chronic pain management service which is uniquely delivered by a voluntary sector organisation. And what they're doing is really collaborating with clinical and non-clinical roles to ensure that people are getting the best support to manage their chronic pain. This service is working with care coordinators at Tier 1, social prescribing at Tier 2, and cognitive behavioural therapy at Tier 3, and clinicians are involved throughout the whole process as people are needing the support. So just to go back to the kind of descriptions about social prescribing that we heard earlier on today, I'm not going to go through all of the bullet points, but I just wanted to highlight the bullet point right at the bottom. And this is coming at it from a viewpoint of public health and root causes, and the fact that we're talking about the social prescribing function, not necessarily social prescribing link workers in primary care trusts, primary care networks rather, which we really, really support. But we also want to recognise that there are voluntary sector organisations and there are individuals somehow who are able to understand social prescribing, or they may not call it social prescribing. They might actually call it helping their client. So in the bullet point at the bottom, what you'll see is that a member of the public came across a lady and her partner that she was supporting from a dementia point of view. This lady is a dementia professional. She was talking and supporting the carer and the person who's living with dementia. And what the carer said was that she's not able to now take part in or access her hobbies because of the type of dementia that her partner had. Now this one is, posterior cortical atrophy, also known as Benson syndrome, which is the degeneration of the cells at the back or posterior of the brain. I'm hoping to read, I've read that out properly because I know clinicians are in the background. But in essence, the person living with dementia was losing their sight, and a lot of the activities that the carer was engaged in involved their sight. So that meant that the carer's health and well-being, their social connectedness, their access to time away from their partner who was living with dementia was being reduced. So their stress levels, their impact on their health was being impacted on their partners. And so when they spoke to Gina, the lady who was actually the dementia professional, what she knew was that there were singing groups in their local area. So just as part of a conversation, when those two people went into the interaction, they just happened to mention, I can't go actually out to my activities anymore because of PCA, so I'm actually at home, I'm not doing anything. So even though the person that she was supporting is a person living with dementia, she realized she knew what a solution was. So she spoke to the carer and said, I'm aware of singing groups. You've mentioned in a previous appointment you love singing. Just when we're having that chatting conversation, I'm actually aware of 3. Why don't you go visit? And so the partner and the person living with dementia went and visited all 3, and they chose the one that's closest to them. So what happened in that scenario was that a professional was not only focused on her own business, she was actually recognizing that her clients come to her with a plethora of issues that are about their situations in life. She has that what matters to you type of conversation, just getting to know people, what their life is like before she delivers what her business is. And as part of that, she came across a problem, discussed it with them, was able to signpost and refer in. So that's about making every contact count. It doesn't have to be a link worker, it doesn't have to be a community development worker. It's just about recognizing that people have needs and they have strengths and assets and what their hobbies are, and having kind of a conversation really with people. So the work that we're doing at the National Academy for Social Prescribing, particularly myself, we're funded by the Independent Age, which is a national charity focused on financial hardship. It was established in 1863, and actually since then it's been helping people living on poverty or just above the poverty line improve their health and well-being and their life situations. We talked earlier on about the evidence reviews, so I just wanted to highlight some of the things that the evidence review that NASP has pulled together was able to showcase. So people are aged 65 and over on the poverty line and just above the poverty line are experiencing food insecurity, fuel poverty, digital exclusion, social exclusion, but also financial hardship in its sort of explicit forms, but in a variety of ways that are also implicit through social connectedness. And sometimes it can well be that because they don't have enough money, they might not be inviting their friends, family or neighbours for a cup of tea because, and we'll all know this, a biscuit comes with a cup of tea. So sometimes it's as simple as that. So what were we doing? We're not only pulling together the evidence reviews, but we are also working with organisations in the community to test out how we might be able to work through social prescribing to support older people's financial hardship. So we're working with the Reaching People charity in Leicester and Hastings Voluntary Action in Hastings. And so Bharti is from Reaching People and she'll talk in a few minutes. What we're doing is, over last year, both organisations, they engaged older people by going out to where they are. So for example, to food banks and food pantries. They co-designed social prescribing initiatives with them, and they are delivering them this year, which we are just beginning to start to evaluate. That evaluation will help inform integrated care systems out there in an integrated care systems guide, which will pull together the biopsychosocial model of intervention that social prescribing can support to impact on older people's financial hardship. And one of the ways that they're doing that is, community face-to-face groups, online groups, in Reaching People charity, some of the sessions that Bharti runs can really be inclusive of different methodologies. So they really focus on the human learning system. They're delivering their social prescribing initiatives through the methodology of live, laugh and learn. And through that, they're providing access to people who've not been in a classroom situation for about 50 years, about how to better use their smartphones, how to use computer basic packages so that they can actually interact with their grandchildren who might not be living at home. So they're really focusing on social connectedness, recognizing that people have strengths and abilities and interests and they want to learn. Sometimes we think that when people are older, they don't, it's it for them. So we have a very cultural pessimism towards aging in this country, and what we're trying to really embed in the work through social prescribing is cultural positivism, I can't say that word, positivity, and recognizing, as colleagues have expressed already, that people have agency, they have strengths, they know what matters to them. We just need to provide them with that opportunity to express that, co-produce with them and work with us. And when we're working with people, sometimes it's really positive to impact on their biomedical experience or their physical health and well-being, some of the things that perhaps you're interested in. So for example, when Leicester is working through Zoom sessions and doing physical activity or knit and natter sessions, some of the participants are encouraged to do activities and so on. So when they're encouraged to do physical activity and try and move their body, what we're finding is that some of the movements that they're engaging is enabling women to brush their hair again, which they might not have been able to do so. But when they're starting those sessions, it's not very much, it's not about, we want you to end up being able to brush your hair again and improve, your life experience. We're having fun. We're here together to do something. So really, it's benefiting so many people in so many different ways, but it's that social connectedness, that togetherness, that's the focus. Sorry, did you have a question? Okay.
Yeah, I guess just to combine with the talk earlier, I think it's quite interesting that in our society, the sort of peripheries of age, the young people, the old people, both.
Yeah, okay. Just to follow on and link the initial presentation and yours about the people at either sort of spectrum of society, the young and old, seem to be having issues with loneliness. And I just wondered, is there anything, as you described, like a biopsychosocial model where we could sort of maybe bring these two groups together? Because it looks like they might, you said, sort of help them become more active, and what your thoughts were on what's available.
Absolutely. There's lots of intergenerational work happening across social prescribing across the country. We have a national organisation called Intergenerational England that is working to really promote both age groups working together. Because I'm working in older people, I'm more familiar with intergenerational work in Bradford, which is where I live. So for example, in Bradford, the school's linking network works with older people in care homes and local schools to ensure that there is that interaction. There's the benefit of the younger people going in with that fresh, bubbly, interactive approach to older people, having that calmness for children perhaps who might be in situations where they might be misbehaving because they're not able to regulate with all the things that are happening in school, all the pressures that perhaps Tracy alluded to earlier on. Also the fact that they are able to ensure that when schools are meeting with people of different backgrounds and experiences, that actually there's a bit of community cohesion happening there. So there's so many different benefits to intergenerational working, and it's a personal interest of mine. So hopefully I'll be gathering a bit more information and working closely with Tracy. I just wanted to highlight also in terms of poverty that we talked about, and I think I'm probably running out of time. We talked about poverty, food insecurity and so on. So at NASP we're working with Independent Age to increase income and reduce costs of people currently experiencing poverty. And one of the ways that we're doing is providing training to link workers both in community settings and in PCNs, or whatever the job title is, anyone providing that social prescribing function, about what is attendance allowance, what is pension credit, carers allowance, so that actually they are informed and able to effectively help their patients or their clients. But also then enabling link workers and social prescribers to understand what skills they already have, what skills they can pick up from freely available training, to talk about basic budgeting and basic household management. We sometimes come across older people who may not have dealt with the life admin aspects, and it's their partner who's done that. And when they're suddenly bereaved, they find themselves in a situation where, unless they're supported, they can end up feeling stressed, perhaps depressed and so on, and that leads to other situations that you're familiar with. We're running out of time, so I just wanted to highlight 2 or 3 of these examples. So one of the things that we're really trying to promote with older people particularly is that everything you can see on this side is what's needed. So co-designing, multidisciplinary working. In Cheltenham and Peripheral Primary Care Network, a frailty nurse is part of the social prescribing team. So I'm just going to reiterate what I've said. The frailty nurse is part of the social prescribing team, not the social prescriber is part of the frailty team. So it's recognising that actually there are benefits to the two clinical and non-clinical roles working together, but it's not about social prescribers being part of a team that already exists. The frailty nurse has joined the social prescribers because she can add value and they can work together. And actually, by joining the social prescribing team, there is recognition that there is value within social prescribing, and that's their approach. And the reason I've belaboured that a little bit is the social prescribing link worker had to really encourage her PCN to understand the community development background that she was coming from. What they do is they not only deliver services by targeting older people using a population health management approach, they actually go out into the community, know what's happening, and the link workers actually take part in the activities that they are co-producing as social prescription, so they can authoritatively and authentically say, this particular venue, even though it's actually 5 miles away from you, that's probably an exaggeration, but it's furthest away from you, but it's the best one for you because you have less mobility, but that the car park and the actual activity are closer than the one closest to your home, so they can really be effective and efficient in what they're doing. There's many more examples. I will be able to share my slides with all my notes that have tons and tons of examples. Please do read them. And I'm going to pass over to Bharti now. I'll leave it there.
Hello, everyone. So my name is Bharti. I work for an organization, a charity called Reaching People. It's a membership organization that brings together voluntary, community, and social enterprise organizations together across Leicester, Leicestershire, and Rutland. Our organization is dedicated to driving positive change through a variety of impactful projects. And I just want to highlight one project, the Refurb IT, where we encourage individuals, organizations, and businesses to donate their unwanted laptops, tablets, and smartphones. We refurbish these devices and distribute them to those who need them the most. Like the elderly, like the young, anybody who needs it. And we work through local charities and partners supporting people who are digitally excluded, whether it's individuals or communities. So it's a win-win, because we're helping the planet as well. In addition to Refurb IT, we also run projects like Health Plus Project, emergency food coordination, leadership programs. So currently, as Nurjana said, I'm focused on the social prescribing pilot project for older people, which is funded by National Academy of Social Prescribing and Independent Age. This project is designed to enhance the well-being of older adults by addressing key areas critical to their quality of life, including health and well-being, financial stability, and digital inclusion. So a little bit about me. In 2018, I started working as a community connector in a predominantly South Asian Gujarati-speaking community. My ability to speak Gujarati and understand the cultural nuances of this community played a crucial role in building trust and connecting with individuals. By fostering collaboration, empowering people, actively listening, and applying positive psychology, I've been able to help create a supportive and a caring community. I'd like to share a story of Mrs. V. In 2015, Mrs. V was diagnosed with cancer, which led her to have severe depression. Over time, she lost confidence and she withdrew from her social circles and had to give up her part-time job. tasks like cooking, opening letters caused her anxiety, and she gradually stopped leaving her home or interacting with others. So when COVID-19 pandemic hit us in 2020, Mrs. V's sense of loneliness and isolation deepened, further exacerbating her depression. It was during this time I met Mrs. V in a car park, where a few of us volunteers and myself were handing out wool and knitting needles as part of a community outreach effort. Mrs. V approached me, and in a moment of vulnerability, because she had heard of me through word of mouth from someone she trusted, she said, "I have cancer." I took her mobile and listened, really listened. I was wholly with her, listened to her story. And because I spoke Gujarati and I understood her cultural background, I was able to connect with her on a deeper level, building the trust necessary to offer a meaningful help. I invited her to join our community WhatsApp group, where we shared information about various Zoom activities like exercise classes, yoga sessions, and social groups such as Knit and Netta, singing, chit-chat. So Mrs. V began attending these Zoom sessions, where she not only learned to knit, but also participated in the exercises and yoga. Initially, she had her video off and she was on mute, but as she realized we were quite friendly, the video came on and she started saying hello and goodbye, and she started to get to make lots and lots of friends. And often in the exercises, she'd feel fatigued. She'd do a little bit and then she'd have to sit down. But she continued to engage. And she started rediscovering her zest for life. The Knit and Netta group became a space of mutual support and creativity. Those who could knit and crochet taught the ones who'd forgotten because they'd done it when they were children, and so people were picking up crochet. Oh, I remember this. And those that had never learned how to knit on Zoom. It was incredible. So together, we made squares. And then we had an expert knitter who joined the squares up and made it into blankets. And these blankets we donated to Action Homeless. We donated about 6 to Action Homeless. And then we did 21 blankets and donated it to Ukraine Appeal. So Mrs. V was an active part of this group, contributing to the knitting projects that not only helped others, but it also gave her a sense of purpose and belonging. So Mrs. V's confidence grew, so did her sense of well-being. Her memory and mood improved, and her family, noticing the positive changes, encouraged her to keep participating. Her monthly visits to see her consultant also noticed the positive changes and wanted to know more. Every visit she said, "Oh, so what have you been doing this month?" and told Mrs. V to continue. With her improved mental state, she no longer needed the talking therapy, which she had been receiving for 18 months. Mrs. V's reliance on medication decreased. Her consultant was so pleased with her progress that he gradually stopped her depression and acidity medications, reducing her trips to the doctors. She once needed 100 paracetamol tablets a month, and sometimes that wasn't enough. Now there are months when she doesn't need any at all, resulting in considerable cost savings for both her and the healthcare system. But Mrs. V's journey didn't stop there. She became an active member of the community, taking on roles as a Zoom administrator. She volunteered with a few others because when things started opening up, the demand was, please carry on with Zoom. So now we do face-to-face sessions, and we've carried on with the Zoom sessions as well. And then she started taking part in the face-to-face exercise sessions, supporting the Knit and Netter group at a local library. But her most remarkable achievement has been becoming a dementia champion, where she now raises awareness about dementia within the Asian community, using her experience and newfound confidence to help others. Where she once needed monthly consultations with her consultant, Mrs. V now sees a nurse. Her blood reports have improved, but more importantly, Mrs. V feels good and happy within herself. Mrs. V's story was shared with her to ensure its accuracy. So I wrote a brief outline, sent it to her just to make sure she was happy, and that's why I'm sharing with you. By addressing not just the medical needs, but also the cultural, emotional, and social dimensions of health, we can significantly enhance the well-being and reduce the reliance on healthcare resources. Mrs. V's journey shows a community-led social prescribing using community-based approaches rooted in cultural understanding and trust. It can really transform lives. Thank you.
Hello. My name is Jasu. Speaking in front of the audience isn't something I usually do. It's make me nervous, but I'm gonna try. Before the COVID-19 pandemic, my life was busy. I had to keep busy, otherwise I knew I would be lonely. At 70 plus, I pride myself on staying independent and maintains a routine to keep me physically and mentally fit. I was passionate about swimming, exercise to music, going out with my friends, whom I saw almost daily. These activities were not just hobbies, they were necessary to my sense of well-being, providing with the purpose of fulfillment. However, when the pandemic hit, everything changed almost overnight. The lockdown and restriction meant I could no longer engage activity, brought me joy and connection. My way of life suddenly disappeared, leaving me feeling isolated and alone. The day felt long and empty, and I found myself struggling with the loneliness. It was during this period I heard about Zoom session organized by Bharti. She was someone I knew from the community. She has started this session to help me people stay connected and engaged during the pandemic. The initial session ranged from chit-chat, singing, yoga, and I decided to give them a try. At first, I was unsure about, I knew I needed to do something to help myself and did not like how I was feeling. Join the Zoom session turned out to be lifeline. Chit-chat session allowed me to connect my old friends, make new ones, while the yoga session kept me physically fitness and mental clarity. The virtual format, which I hadn't initially been unsure about, became a new way of meeting people and staying connected. I realized I was not the only one feeling lonely and down. The session gave me structure to my days, provided a sense of normality, and felt anything but the normal. As the months passed, Bharti approached me with a new idea, knowing my love of Sudoku. She asked me if I would be interested in leading the Sudoku class on the Zoom. So I was delighted but nervous by the idea of giving a try. We decided to combine the Sudoku class 30 minutes, exercise to music session, creating fun and engaging way to stay active both mentally and physically. Bharti handled the technical side and put me at ease and gave me a confidence to do it. Leading this session was an incredible, fulfilling experience. I found joy in teaching other people how to solve easy Sudoku puzzles and positive feedback I received from them. The session became more just a class and became a space for connection and community. I engaged my friend to join, and soon we had a regular group, and who not only enjoyed the session, but they formed meaningful connection with one another. At the peak of COVID, I used to have 70, 80 people joining the Zoom session. Our friendship deepened, and we became a close-knit group, supported each other. Looking back at this time, I realized how crucial these sessions were to my mental health. Without them, I would feel incredibly isolated and likely would have struggled with a depression. The session provided me with a sense of purpose and a connection that was vital to my well-being. I'm certain that without this support, I might have needed medication to cope with the mental health challenge brought to by the isolation. As the world slowly began to reopen, I was eager to return to my regular classes, swimming, the activity always been important to my life. I was excited to resume them. However, during this time, I had an accident. I suffered a setback. I tore my muscle in my shoulder, which caused me a lot of pain and limited the ability to move my arm. The pain was made impossible to do my usual activity like swimming, exercise. In fact, that was struggling making chapati or opening the jar or dressing myself. Given my age, the doctor said I wasn't right candidate for the operation. So they presented with me the managing the pain through the non-surgical means. I was not happy. After the couple of months of having the shoulder pain, I received a letter from hospital. The tear was big, so I needed the operation. After much thought, discussion with my family, I decided to go ahead with my operation, knowing that the recovery time takes 3 or 6 months. It was not an easy decision, but I knew it was the right one for me. As the day surgery approached, I began to worry about how I would manage. During my recovery, my daughter lives in Australia, my son in London. Both were very busy with commitment. I didn't want to impose them any responsibility were demanding. The thought of facing recovery alone was daunting, and I wasn't sure how I would cope without any help. However, what happened next was nothing short of blessing. My friend, who had become like my family, they all stepped up in the way I could never imagine. The couple of close friends, along with my sister who lives across the Leicester, who doesn't even drive, but rallied around me. They bought me food, did my shopping, and made sure that I had everything I needed. Every day someone come to my home and spent time with me, ensuring that I was never alone, and support me invaluable, both physically and emotionally. They took care of my practical aspect of recovery, but more importantly, they provide me with a companionship, emotional support, which I have believed helped me to recover quickly, knowing that I had a friend who cared for me deeply, which very comforted me. Their help meant I didn't need to rely on adult social care service, which I was relief both for me and for my family. As I began to recover, I found myself eager to reconnect with the wider community. Resuming my role in supporting Bharti with the admin for Zoom session was a natural step. It gave me a renewed sense of purpose to allow me to stay connected with my friend. Gradually, I started going out with local community center, attending events outside I was worried about. Possible someone bumping into my shoulder. But my friends came to rescue me as they take care of me, and I become more confident. I started using the bus and even driving the car. I know without my friends, my recovery would have been longer and more difficult, and would be definitely needed external care service. My friends are more than just people. I socialize with them. They are my family, my support system, and my lifeline. Thank you.
thank you, panel, for really bringing social prescribing to life, and your story is just perfectly demonstrates how social prescribing for you was a preventative approach to your health situation not getting worse, but it also worked as an adjunct to existing conditions, and I think that that just shows the kind of breadth at which social prescribing can really support individuals. So thank you again for bringing that to life for us today. As to not deprive you from your break, unfortunately I'm gonna cancel the question session for this, but we will all be around to answer your questions throughout that. After the break, we're going to be hearing from Dr. William Bird, Giles Wilmore, and Louise Montgomery, and we're going to be looking a little bit more in depth at that kind of whole system to social prescribing. So what does that social prescription sort of look like? But do take 15 minutes. We'll come back here at 3:25 for that final session, but do go grab some refreshments and hopefully some biscuits too. Thank you. Welcome back, everybody. I hope you feel refreshed after your short break. So this final session that we're going to be going through today, and again, I'm going to take us back to that definition and that third category that I mentioned in terms of the latter end, so the social prescription, the bit at the end of that referral journey that happens for that patient going through a social prescribing pathway. In NAS, we like to categorise those social prescriptions into 4 pillars, and those are the most commonly referred to categories, those social prescriptions. It's not prescriptive, ironically, in that quite often things happening in sort of varied ways. So you might see an arts and culture prescription happening in adjunct with a physical activity prescription. The 4 categories are physical activity, arts, culture and heritage, nature, the natural environment, and information and advice. It will probably come as no surprise, but when we recently did a survey with our link worker advisory group, that information and advice category was the most commonly referred into. It came up at the very top of the most commonly referred into activities from that link worker advisory group. That's because that's where things like housing advice sits, benefits advice. You know, people are coming to social prescribers with a lot of the time that very immediate need for that situation. However, activities such as music, such as the natural environment, can also support people through those immediate crisis points as well, and are just as valid interventions. So I'm really, really pleased that we've got panellists that are going to speak to those things at the moment, not least because music is my background. Music and dementia is something that I've been passionate about for a really long time, and have seen the power of how it can really sort of change and shift people's lives. So to hear a little bit more about the work that's going on in that arena, I'm going to hand over to Giles Wilmore. Thank you.
Good afternoon, everybody. The first thing I have to check is that you can hear me. Is that okay? Tall man at the microphone, so I don't have to do my giraffe at the water or my diagonal man artistic installation. That's all good. Okay, so rather interestingly, I have a background in neither music or dementia, but that's what I'm going to talk about. That's the power of social prescribing. So I work for this organisation, Manchester Camerata, which is an orchestra based in Manchester, and I'm going to talk to you today about this programme called Music in Mind, which is a music programme for people living with dementia. So yes, this is Camerata. When I was offered a job with them about 18 months ago, and I rang my brother up, who's a huge classical music enthusiast. He was very jealous, and he said, "You working for an orchestra?" And I said, "Yeah." And I was a bit sort of taken aback about what this was going to be, but actually, this is the public perception of an orchestra, and of course this is something that Camerata do, but what I found out is that there's a huge and thriving community programme. So Camerata, as it says here, have opened the stage at Glastonbury, the Pyramid stage, with their Hacienda Classicals. So they've worked with musicians in the community to reinvent the Hacienda nightclub music scene and interpret that through classical music. We'll have our Christmas concert soon, which is a beautiful collaboration with the African Caribbean community in Manchester, who bring gospel singers to sing alongside the musicians. So music is a powerful vehicle, and as our orchestral conductor Gabor said, music is a spiritual medicine. And this is something that really struck me in the community work that we've been doing at Camerata. We have quite a lot of work with young people in schools and colleges, but I'm going to talk to you today particularly about our programme with working with people living with dementia. So my background isn't musical at all. I've been on a long journey in the healthcare system as a manager and a commissioner of services, working at national level with NHS England, the Department of Health, regionally in Greater Manchester, and indeed as a director of strategy at a hospital and community trust. So I think over the years I've seen the healthcare system at all sorts of different levels, but now I'm on the other side of a table, as it were, working for a charity that's providing a health and wellbeing service into the NHS. And the reason I was recruited into this wonderful organisation of musicians is they tapped into this programme, Music in Mind. They knew it had huge health and wellbeing benefits, but they had no idea how to connect it with the health service. Just as we were hearing about before the coffee, that was the bottleneck. So I came along. I'm learning a lot about music and a lot about dementia, and hopefully helping these wonderful people get their service connected into the healthcare system. So what is Music in Mind? It's a music therapy-based programme designed for people living with dementia and their carers. Crucial that. Family carers are crucial in all of this. It's group-based musical improvisation to encourage people with dementia to express themselves. So we're not performing at people, we're making music together. And as you said earlier on, Debs, if you can write on a scratch, I think you said a mark on a piece of paper, you can draw. If you can bang a percussion instrument, you can make music. There is no right or wrong music here. It's about expression, communication, connection, and really bringing people together. That just gives you a flavour of the power of what music can do, and it speaks eloquently, I think, far more so than I can do, about the impact it can have on people's lives. And Keith joins our group there. The building you saw in the background is Gorton Monastery, where we're based. But we're now, with the help of the National Academy of Social Prescribing and others, spreading Music in Mind right across Greater Manchester and hopefully further afield as well. So I'm going to tell you a little bit about how we hope to scale this, make it sustainable, and how it links with social prescribing. So our model for scalability and sustainability is to work with what we call music champions. Because one of the challenges with this is if you're reliant on professional musicians, orchestral musicians all the time, well, for a start, we don't all happen to know half a dozen orchestral musicians with spare time to come along and run music groups. And if we do, they're quite expensive. So what we're doing is we're training community staff, care staff, because this programme runs in care homes and supported living as well, volunteers in partner organisations. We're training them in some of the core therapeutic skills of facilitating these groups themselves. We call them music champions. There's a community of 60 or 70 of them now in Manchester. We've got ambitions to recruit another 150 to train and support them. So we have a whole range of recorded backing music, so they don't need to play a musical instrument. They can if they want and they know how to, but it's not an essential requirement. And what we're really doing is bringing joy to the lives of people living with dementia, social connection. And there's a lot of evidence around this in terms of the confidence and skills it gives both the people taking part, carers, as well as the people living with dementia, but also the music champions. We've had great testimony from staff in care homes about the new skills and confidence it's given them in their job, reducing agitation, creating an atmosphere of calmness. One carer telling me she's now worked out that singing when she's trying to shower residents early in the morning just creates a much calmer atmosphere. There's less agitation, less distress, less worry, etc. All these slides have got embedded films in them giving more testimony from different perspectives, and I'm happy for them to be shared afterwards, but I won't play you anymore now as we won't have time. So yeah, the work has been a partnership over the last decade or so with Manchester University, so it's well researched and evidence-based. We've been working with Professor John Keady, who's a professor of dementia, and his team. The primary focus of the research to date has been about the benefits for the person living with dementia. They've done 2 or 3 significant studies. Dr. Dowland did her PhD research study around the benefits in the moment and how the benefits of the music affect the person living with dementia. But we're also looking increasingly at the cost benefit, the financial business case, and there's a lot of evidence to suggest, as I say, in reducing the agitation levels of people with dementia, you can start to reduce the need for things like antipsychotic drugs. And so that'll be a key feature of the work going forward. Does it work? Well, again, lots of evidence around reducing agitation, There's a quote from the All-Party Parliamentary Group on Heart, Arts, Health and Wellbeing. And from our own research, we found that over 90% of participants have expressed positive increase in social connection, communication skills, and decreased levels of frustration and anxiety. And the softer evidence, the testimony, the quotes that people give you, it really is that it's life-changing and life-affirming. And it's fascinating listening to some of the discussion before the coffee break about what the NHS chooses to fund and what it doesn't, because we are grateful that the NHS in Greater Manchester is match funding this programme to enable us to scale this up. But that's really the exception rather than the norm, I have to say, sadly, for something of this scale to be funded by the NHS. And yet, if you ask any one of these people who come along to the group, who get very little support living with their dementia, who are largely confined to home, you know, what service would you cut first if you had to reduce costs? They're not going to say this, I can tell you that for certain. This is the highlight of their week, it's their lifeline, it's their one opportunity to get out, to feel normal, to socialise, to connect, to feel good about themselves. So, moving on to what we're doing now. This is the programme that we're being supported by the National Academy of Social Prescribing to take forward, a centre of excellence for music and dementia, based initially in Greater Manchester, but you may have seen there's been a call for a second area of the country to come forward, so we're looking to expand and grow this model. We're working with a range of partners, both nationally and locally. So within Greater Manchester, we've partnered with the Alzheimer's Society, as well as our NHS and local authority colleagues. We've had strong support from the Mayor, Andy Burnham. As I've already mentioned, research partners in Manchester University again, because it's really important going forward that we evaluate and research the impact of this programme as we go along. And crucially, we're working with a load of community partners. So all these organisations on the bottom, in fact several branches locally of Mind and Age UK, will be hosting what we call music cafes. So these are the community venues where music groups will be happening, and it's the staff and volunteers of these organisations that we're training to facilitate and run these indefinitely. And the last programme we ran, we had 17 different centres that were trained about a year and a half ago, and 13 of them are now still running under their own steam without any active input from Manchester Camerata. So we know it's a model that's scalable and works. And the last slide, oh sorry, that's a bit dark, isn't it? I have to change the background colour, but this will work as a sort of live example of social prescribing, because at the moment there's very little for somebody with dementia who comes to their GP and wants support in the community. So this gives us an option. It means that we'll have 40 music cafes across all 10 boroughs of Greater Manchester. We're launching the first 10 next month. So wherever you happen to live in Greater Manchester, it'll be possible to be referred into a music cafe. So we're building connections with the local social prescribing services and our host organisations. Throughout this programme, we'll also train 300 music champions, 150 with Manchester Camerata and 150 with Alzheimer's Society. And our ambition, the target we've set ourselves, is to support at least 1,000 people living with dementia, which is quite a significant number. But to put it in proportion for you, that's only about 2% of the dementia population of Greater Manchester. And yet this is a significant scale of programmes. So it gives you a sense of both the challenge and the opportunity. And when I was negotiating the match funding, I don't think I told you this, Charlotte, but when I was negotiating the match funding with the NHS, the Director of Commissioning, he did his maths and he said, that's about £1,000 per person, isn't it? I said, yes, over 3 years though. So it's about £350 a year per person. And I said, what dementia services can you provide for £350 per person per year? So I think the voluntary sector represents huge value for money, given all the evidence about the benefits that this can bring and the continuing benefit. But this is the argument we have to continually make. And so just to finish, what we're doing to try and really embed this culturally in the hearts and minds of our NHS and clinical colleagues is I'm working with the lead GP for the Greater Manchester Digital Care Record, who's already agreed we can incorporate music for dementia into the integrated digital care plan. That's quite significant because that's been piloted now. As it rolls out, it'll provide an opportunity for any clinician referring or supporting somebody's care with dementia to have the option of seeing, oh, well, I can refer into music. I can provide music as the support. Of course, it's not going to be for everybody, but the opportunity will be there, and it'll be built in to the care and support planning process, so effectively part of the dementia care pathway. We're also using data from the Great Manchester Care Record to do the analysis going forward with Manchester University to look at the impacts of the kind of evidence you were hearing about this morning around the extent to which this may alleviate pressure operationally on the NHS. My strong suspicion is that across this cohort of 1,000 patients, over the next 2 to 3 years, we'll see significant reductions in ambulance call-outs, A&E attendance, GP appointments, even drug prescription, etc. But that'll be interesting to find out. And again, I'm not saying this is a cashable saving for the NHS, but when the NHS is under such huge pressure, it's about supporting people in the community in a way that's wholesome and fulfilling for them without having to call in precious NHS resources where they're not perhaps needed as much as in other ways. And finally, there'll be a big component of this which is about sharing the learning. So we're going to be a leading part of a national learning network. There are at least 60 smaller community-based organisations who've also benefited from Power of Music grants from the National Academy. So we're already bringing them together at an event later this month in Manchester to start sharing the learning. There'll be a whole programme of webinars and other support for them as well. So we try and challenge this cultural barrier of music being seen as a therapeutic support really for health and well-being, and not just as something that's fun or entertainment. So I think I've gone over slightly by a couple of minutes there, so I'll pause there and hand back to you.
Thank you, Giles. I mean, it's truly innovative. I mean, social prescribing argumentatively is innovative by nature, but I think that's a really sort of innovation in terms of it looking at that system change, which that learning is just going to be absolutely invaluable. And also, I think dementia people with dementia being supported through social prescribing across that pathway, as you say. So actually, how can even pre-diagnosis social prescribing being had as part of that conversation to not just support that individual, but also the family through something that can be really, really challenging as well. So I think, yeah, that's really, really exciting. Don't worry about going over time, because I forgot to mention at the start that unfortunately Jules isn't here today because she's not very well. So I think William is going to be doing a little bit of a blend of presentations, but we have got Louise at the end who'll introduce herself as part of the panel to give that perspective too. But I'll hand over to William now. Thank you.
Thanks very much, Monica. And so really good to be here and to hear all the stories and all the work that's been going on. And I love the music, and in fact, dance is the other thing, which I've got a real keen interest, and we might be hearing more about that in the new year. So I'm a GP, and I've been kind of really pushing about, I would say, social prescribing, but I started health walks and green gyms back in the mid-90s, so it wasn't quite back to 1984, but have been really understanding that the power of community coming together and nature particularly had a real impact on my patients who right back in as a fresh-faced young GP, and it was about the diabetic patients. But what really kind of I feel we need to try and do is understand what's going on under the hood, what's going on in the body that links all of this together. So I'm going to talk about nature as well, but I'm going to try and bring it all together so that we can understand that there's some kind of unifying effect that's taking place. So hang on, let's see, where do I do that? There we go. So what does make us resilient, and is resilience important in all of this? So if we look at what a human brain, in fact any animal brain, actually needs, there are three things. One of them, you have to feel safe. That's what the whole brain is designed to do, is to protect you. And everything, when we're not feeling safe, will go into alarm mode. The second thing is we need to belong, and we've heard that so many times. Particularly humans as a mammal are very sociable. We're incredibly sociable, and we've know a lot about the research, how important it is. And the final thing is, and then that great thing is what matters to me, is that feeling valued and people being listened to. And we've heard that a lot about being not listened to, being treated as an output, being treated as a number, the consultation being interrupted every 11 seconds by the doctor. That is against feeling valued. And that's it. I can end my talk there, because if you have all those three, you've got everything sorted out, because the body doesn't need to then go into defense mode, because it's got everything it needs. But there are three domains of our life. They're the people around us we interact with all the time. There's the place around us that we interact with. And there's us, our purpose. Why are we here? Why do we get up in the morning? What's planet Earth got to do with us and us with planet Earth? So that's the purpose bit. And then, of course, being a bit geeky, you put them together as a matrix, and you suddenly get 9 squares. And you can actually start to understand where all the things that we've been talking about start to fit in. So safety around people is about trust. It's about compassion and kindness. Go to the other end of place and safety, it's that security. Do I feel safe? Do I have that psychological safety of the place? Do I feel safe there? And in the middle, which is really where they all surround, is us feeling valued ourselves, valuing ourselves. And Deb said, you know, you didn't value yourself, you felt other people were looking at you. And discovery, you've got the capacity to start to discover things rather than shut down the whole time. And you can look at all of that. Now, I'm not going to pretend that every part of that is all evidence-based, but there's a lot of those 3 areas on either side that are evidence-based. And this acts as a good grid to be able to work out what we're doing. So if we try to understand what's happening, if you've got strong resilience, and particularly in children, where they feel loved, they feel secure, they feel they've got their boundaries, they feel they know what's going on, then when stressors come along, you get an acute stress response. That's normal. You get your adrenaline, noradrenaline, cortisol, and other things, and then you recover. And that's called hypostasis in the techie language. It's a better state. And in fact, your resilience has increased because you've overcome some problem and you've managed to deal with it. And that's where coping is better than the stressors, because you've overcome it. If it goes wrong, and there are lots of reasons it can go wrong, either there are too many stressors because you're living in a very deprived environment, or you haven't got that resilience, you don't feel loved, you don't feel you're cared for, you don't feel valued, you don't feel you belong anymore. All of those things start to fall apart, and therefore the acute stress response comes up. That's normal, but this time you move into chronic stress, and it's got names like toxic stress or catastasis, but you're no longer in a recovery point, you're actually in a hypervigilant state. And let's just have a look very quickly about how nature impacts that bit, and then I'll go back to that kind of diagram we're going through. A lovely study done in Berlin where they got people to walk in nature or in an urban area, and then they looked at their brains through fMRI scans. And what they found was just after 60 minutes, the amygdala, which is the bit that really looks after your fear and makes sure you're going to be safe because it puts up the fear, in the urban area, it stayed about the same, but in the nature area, the blood flow to it and its metabolism dropped significantly because suddenly the body felt off guard. It felt it didn't need to be so vigilant all the time. You imagine children walking in nature compared to urban all their life, how many thousands and thousands and thousands, 60 minutes is that? And no wonder their brains change and the amygdala gets bigger. And we know from many reasons that actually that does take place. The hippocampus, which does behavior and learning, that went up in nature. Again, that's really positive for people. This is after 60 minutes, so it's like exercising your muscle. It might not make much difference for that time, but if you keep doing it, your brain starts to change shape. And even the frontal cortex, which does all the nasty kind of rumination, of negative rumination, which eventually leads to depression, that actually gets reduced significantly in nature. And if we look at that matrix and we look at, you feel safe, not all nature, and I have to say some nature people don't feel actually less safe, but most nature people feel safe. Their instincts are that the brain says you've got food, you've got shelter, you've got water. That goes right back to primitive state. And nature seems to have that effect. Lots and lots of stress research has shown that that's reduced. Now, if we go back to that threat, the urban environment perhaps, the stressors now are overtaking the coping mechanism. And that link between acute stress going to chronic stress is probably the biggest shift that takes place in to create poor health. It certainly as a child, those with adverse childhood experiences means that your brain is now in a hypervigilant state and you start to get stress hormones pouring out all the time. And then noradrenaline and ACTH. You're in a completely different state than if you don't have that acute stress. But that creates negative emotions. They're all there to protect you. They're not negative. They're absolutely normal, positive emotions to protect you. But if you've got them all the time, they become negative because they stop you from interacting with other people. You don't want to. You want to shut yourself away. Fear, anxiety is protection. Anger is fight and flight. Aggression is fight. Sadness is a depressive part which pulls you back. Even tiredness is now thought to be an emotion from some psychiatrists and psychologists. Jealousy, all of those are to protect you. And you stop interacting with other people because they become a threat. So you lose trust in people. And then you get the unhealthy behaviours. We tell people, say, well, just get more exercise, just eat a proper diet. Come on, just sleep. You know, just shut your eyes and you go to sleep. What's the problem, you know? Well, if you're in this state and your body's feeling it's under attack, sleep makes you vulnerable. So you can become hypervigilant. Inactivity, lots of evidence show that under stress, why waste calories? The one thing you want to do as an animal under stress is to conserve calories as much as possible. Eat as many calories as you can. Your hormones change, so you want to eat the nasty stuff. And then you store it as fat and don't let go of it because it's all about conserving calories when under pressure. And smoking, because the frontal cortex changes, your inhibitions go, and you're having a miserable life. So you just want to have distractions. So alcohol, drugs, smoking all get bigger. So this is all normal. And yet we know it leads to real problems later on. And then it gets to the geeky part, which I won't go through because I was about to bore Charlotte earlier on. Chronic inflammation is when the immune system gets in the act to defend you. And that goes up and that causes chronic inflammation in the whole body. That interrupts your mitochondria, which is basically the most important little part of the cell. Used to be just thought of energy. And those two start to get into a right old tiz with each other. And those two books, one from a psychiatrist at Adam Brooks and the other from psychiatry at Harvard, are basically saying most psychiatry, if not all psychiatric illness, is very much heavily to do with this. People might disagree, but read the books and see what you feel because they're pretty eminent people and it's starting to really take shape. And then this study that was done in Nature, that was in, when was it, 2019, showing that pretty much all long-term conditions may be due to chronic inflammation. So we've got one key bit over here causing the problems, and we've got the chronic stress bit at the top, key to everything that we're talking about. And all those consequences all start to make sense and become normal. So Frank, diabetic, had abuse as a child, alcohol, smoking, all the problems that we've seen, all because his state remained vigilant all the time, and we can get him out of that. Urban green space can reduce chronic stress. We can see that all those little horrible kind of little acronyms of CRP, SAA, LDL, all of those are stress hormones. They are all decreased in an urban environment in people who live near a green space and increased where there's no green space. And there have been a lot of studies on that. So I'm going to go through now, very quickly, each of those squares. And it can be literally 2 seconds on each. Compassion, trust. Nature increases people's trust in each other. They start talking to each other. you're going to be quick on photos, but you'll have the slides afterwards. Residents have been found to listen more, and you actually get more sociable when you're in nature compared to a concrete environment. The less green space there is coincides with feelings of loneliness, even if you've got the same interaction. So nature acts as a surrogate partner to you, a surrogate friend. You don't have those feelings of loneliness quite as strongly. As opposed to people who used to think vegetation made things worse in an urban environment, domestic violence decreases. Incredible studies done which show that very powerful and less aggressive and violent behaviour. You can get the natural beauty, so nature really does seem to make it's the beauty of it, and then in a town, etc., connecting to landmarks which are nature, really reassuring of trees and other things and mountains and other parts of it, lots of security there. And finally, people flourish more. It's a very interesting conception. So you can see that nature fits everywhere. And then all the other stuff about cardiovascular mortality, all-cause mortality, type 2 diabetes, strip away all the other parts, and nature seems to have a direct effect on that. So we've got nature fitting into pretty much every single part of this model, and all the evidence is sitting there. And so the systematic reviews that's been done showing fewer prescriptions, lower healthcare costs as well. So to kind of sum up the kind of how it works, if you've got nature, the stress reduction we've seen is really important. The social contacts, pro-social behaviour of nature is probably the most important part of it, even as important, if not more important, than stress reduction. Physical activity is a weaker one. It's not a very straight line of association, but it's pretty good. And then obviously the cooling of the cities and making sure that you've got runoff and all those physical aspects of it. And then actually the only thing that's not on there is the gut biome, the little bits of bug you pick up when you're in nature, hugely important for children growing up and have a functional immune system. And as we've seen, it does all of these things here. So the green space, not surprisingly, narrows the health inequalities gap. This is about 2 million people, I think it was, on this. And it showed if you have little green, the mortality of people with the lowest income is very high, and the person with the highest income is stays about the same all the way through, in fact. But you can see how the people with the lowest income, as they get into a greener space, if you think about a toxic environment of lower income and all that hypervigilance, if you've got nature, you're going to impact those people more. And the gap between the deaths between the rich and the poor in the green area, adjusted for a billion other things, and then for little green, is huge. So just put green in space which people really value, and you've reduced your inequalities. Whew. Right. 2 minutes?
You got 5, actually.
Oh, have I got 5? Oh my goodness me. Who's been told that before? So this is a breather. So I'm just going to say some of the work we've been doing with the Eden Project. So I also run a company called Intelligent Health, which does beat the street. We've reached about 1.93 million people, mostly from deprived communities, doing a game which engages them, half children, half adults, connecting to nature, connecting to communities, building up their resilience, and we measure their resilience. But what we were looking at particularly is just putting green space, is that enough? And we did this work in Reading. So we had 6,540 people in a very small part of Reading. We tend to get about 20% of the population playing this, so it's a huge number. It's enough to really, in fact, it's about 30 to 40% of all children in that area will play, school children. And here we measured their resilience. We put a question on all of those boxes, and this was for adults. And you can see here that there's a big blob of very high resilience in there, but very low resilience here. And this blue line is their low Warwick-Edinburgh score. So there's an area of poor mental health there and poor mental health here. And then we superimpose that with the resilience. And then, in fact, there's the, sorry, it's the wrong way around, and there's the Warwick-Edinburgh scores on those areas which have been pointed down. Then we looked at who had visited Prospect Park, because we can actually find out where they go. And you can see these are the little beat boxes where they can go to. And you can see that actually everyone who had the high resilience have all visited But these groups of people over here who had the low resilience and the low mental health haven't been visiting the park. It's right next door to them. They live on the border. So by going in and targeting some of those areas, you begin to start to understand that this is because they feel frightened of going out. They want to just keep the security. Going into a park is a big, big thing to do it on their own. So they need help. And that's where green social prescribing is essential. So those who say just build green space and they'll come, it's not true. Because you haven't got the resilience, you haven't got the this confidence to be able to go into nature. And it needs help. It may sound strange for people who go out all the time. We look at it through our own lens. But when you talk to those people there, and also there'd been a murder there 20 years ago, that's still very much in people's mind. It was 20 years ago, and yet it's still thought to be a dangerous place, and it's gone down to generations very often. We can then go down to this road, and we've done a lot of work with a charity there about D Road in actually getting people back into that park and to the woods behind. And it's taken 10 years for that charity to finally get that barriers broken down, that it's a safe place to go, and particularly the woods at the back where, again, there have been prostitutes and drugs and for many, many years. So getting people, communities back to nature is a long-term problem. It can be sorted out, but it takes time and it builds the trust. You have to have that trust. Now I'm going to do a little bit of just a bit of work which I think we were going to get from Jules, but just to see what different parts of nature there is. Well, there's conservation, the Green Gym, so I helped set up back in the 90s. Thrive, one of the organisations to do horticultural therapy, but horticultural therapy is throughout all the green social prescribing pilots that there were in the different parts of the country. That's one of the biggest areas that they're taking place. You may have heard of forest bathing. I hate the term, but it always sounds very strange. It comes from Japan, but actually just accepting yourself as you are in a forest can be an incredible feeling, and the evidence of it is really, really strong. But just going for walks, again, the Ramblers have taken over the health walks, which I started some time ago, but that is just simple, where you're going with other people into walks, and all of these have got evidence, and even care farms. People with very severe mental health find it incredibly satisfying to be with animals and having a purpose to do. So Jules wanted to make me aware that they're the, is it 7 pilots? Yeah. It is 7, isn't it? Yeah, so the 7 green social prescribing pilots, which we heard earlier, which were funded by Treasury and had Department of Health on there. Finally, we got the evaluation through, which, as Charlotte put out, was really looking very positive. And we're starting to see, and what I think Jules really wanted to say, that this is value for money. We know it's effective. We know it's equitable. And she did want to kind of quote that, not as a kind of downer on the DNAs, but 50% of all patients going to talking therapies don't attend. And that is something which we have to look at. But if it's something people really enjoy doing, like we heard with the music and like we've heard with others, people will want to come because it's not a service anymore. It's just part of you. It's what you're loving. The group brace work is so also important. And obviously we've got the evidence now showing that you've shifted from the diagnostic of depression to not being depressed. I always think in medicine we're very good at having these artificial kind of points all the time. But if you think about that mode where inflammation is going from children all the way through, it's a continuum. And it's when you hit those criteria, we suddenly say, now you've got depression. Now you've got diabetes. Well, it's been sitting there all the way through, just building and building. So the fact that we can speak that language and show that you can reverse some of that depression through green social prescribing, I think is really, really important. So finally, nature is a buffer to chronic stress. It can help, particularly for children, for later on, but adults as well. The chronic inflammation and all those other things, it can stop that whole cascade going down. Don't forget, some people do find nature as a threat, particularly some types of nature, animals, being lonely, being outdoors where you're feeling cold, and lots of things where people kind of don't assume that people will want to go to nature. And getting them over that threshold, like in that park, we do need green social prescribing, and really, but we have to fit that in. We heard about going back to the place where the problem started. With green social prescribing and any social prescribing, it has to be a system change. There has to be something about the whole environment and community that changes, not just an isolated thing, and then people go back to the problems that they were. We have to start working in that place-based system role. Thank you very much, Monica.
Thanks, William. Perfectly demonstrated at the end in terms of that whole system context to social prescribing, and the link workers are often the ones that are mobilising those assets, of which there are a wealth of in the community. They're the ones that are often having that what matters to you conversation. But in order for that whole pathway to happen, there are many different roles, responsibilities of sectors and professionals to kind of realise their own contributions towards that system, and I hope that's something that you will have all taken away from today. We've got about 10-15 minutes for questions, but firstly I'd just like to introduce Louise, who's very kindly stepped into the panel with Jules being away. Louise, could you perhaps just introduce yourself and a little bit about what you do at NAS?
Sure, absolutely. Good afternoon, everyone. I have been asked to fill Jules's very big shoes on the panel, but I am the national lead for the natural environment, and I work very closely with Jules, who is the program implementation manager of the Green Social Prescribing Test and Learn extension. You've heard that the report has finally come out, so I encourage you to look at that with close eyes on the recommendations. But I work with the national leads, Nurjahan and Tracy, you heard from earlier today, as well as Jules and many other of my colleagues, looking at how we can spread and scale social prescribing and green social prescribing without making green social prescribing seen as a separate offer. So it's about folding it into that wider offer nationally.
Thanks, Louise. Does anybody have any questions? We've got the mics around. I'll come to you first in the black coat.
This was a question for Mike. Just wondered if you could leave the last slide up, because it went by quite quickly. I don't know if we get the slides. It was an excellent talk for Dr. Mike.
I think we will be sharing the slides.
That'd be wonderful.
Yeah, we will be. Just seeing if we can get that final slide up.
Yeah.
Thank you.
Just wanted to ask Dr. Bird whether you had been embraced by the powers that be, so, you know, the NHS, NICE, these sort of people that essentially most of us who work clinically, you know, have to follow their guidance, etc. And also Mid-Essex, is that where you're based?
I'm actually based in Reading, but I'm actually chair of Active Essex, one of the active partnerships in Essex.
Yeah,
so hence the Essex connection.
Yeah, because, you know, they have a big NHS trust, don't they, MEHT. So yeah, just wonder if you could elaborate a little bit, experiences, suggestions.
So I think, I mean, yes, we do need to get this in. Do we need to get it into NICE, and do we need to get all those protocols? I sometimes wonder, you know, I remember trying to get physical activity into QOF, and we spent, you know, years with the Department of Health doing it, and finally it went in. It didn't make a jot of difference. And I think, you know, we can kind of try and jump through the hoops, but there should be enough evidence from NICE and others to be able to make sure it's included. When you look at every single clinical condition of diabetes and hypertension, there's some really strong evidence now about how physical activity, but green exercise or being out in a natural environment adds another bit. But it's always that kind of problem then, you know, what are they recommending, or what are they, you know, it gets all tied into knots, etc. And I just wonder if they should make some very vague kind of discussion, just to say, look, have a look, we won't prescribe it exactly, we won't make it right down to the detail, but we'll just say, it really is in our interest, we think there's something there. You know, I wish they could be a little bit more open on that rather than closed down. But I do think if they did say something, it would make a difference. And I think that's something we should all be trying for. And that goes for all social prescribing, like for music as well. You know, that should be something that NICE should be right on to.
Yeah, and amazing. And just to tie into what the chap to your left was saying about dementia, I still remember at medical school when we were showed with a chap who had a sort of resistant dementia, wasn't responding to anything, was just, you know, not engaging with anyone. And they played music from his youth, and suddenly he came alive, he was dancing, and, you know, that really stayed with me. So the power of music and nature to heal, I think, is hugely underestimated was very powerful talks from both of you. Thank you.
Thank you. And if I can just say, yes, absolutely. There are a number of films like that. In my slides, there are links to our website. Please look at some of the testimony. I think those of you who are, I'm not, but those of you who are clinicians will know that with most forms of dementia, it's the recent memory that's most affected. So the distant memory back to childhood and adolescent years, where music can be a formative part of people's life. It's a form of reminiscence. It's a form of connection with who they are and their identity and what makes them who they are, even though they perhaps don't see it like that. And I think that's why it's so powerful. And what we find is we have to adapt the music, because we're dealing with a generation of people now whose childhood was probably the Beatles and the Rolling Stones, not Vera Lynn. And we're also looking at music that's culturally diverse. In Greater Manchester, we have big communities from different ethnic backgrounds, and we're looking at Bollywood-themed music, reggae-themed music, so music that resonates with people and reminds them of who they are and their identity is really important.
Yeah, I mean, I work full-time in the NHS, but most surgeons and anaesthetists put their favourite music on in the background to calm them down, you know, if they're dealing with a life-threatening operation where their cortisol levels are sky high. So, you know,
that's comforting to know.
Yeah.
In case I'm ever a patient on an operating table, you wake up to hear that.
Well, you know, emergency surgery, it's all part of the... I think doctors are human too, aren't they?
Just this lady with the beige blazer. So we're just getting a microphone to you.
Yes, thank you very much. I'm a fellow at the Royal Society of Medicine, and I'm very pleased to see social prescribing is on the agenda, because I also work in the local community and have worked in the local community for about 30 years after a career in the health service. But my question is really understanding social prescribing at local level. Social prescribing is really new, and we've heard a lot about community initiatives today, and you know, they're absolutely immeasurable across the country. And how will social prescribing really do its job as linking individuals within the community better with all the services that actually are available already? I'm thinking now also of a little cameo that people in the community are totally confused about all the different people they see within the community environment, healthcare environment today. I run a carers group for carers of people with dementia at a local caring cafe where we regularly have music and where actually it is transformational to the individuals, some individuals. But to backtrack, this carer was saying that they'd seen a social prescriber. They didn't know it was a social prescriber. They asked me, well, what's this person that I was recommended to have a conversation with? So that's one problem to me. And my son, actually, another individual, said he was going to see his GP about a sports injury. He wasn't seeing the GP, but he was seeing somebody else, apparently. And you know, and I chair a patient participation group for a health centre, so I'm in that environment. And it's a real issue, you know, around all the people that, the members of the team, the physician associates, the care coordinators, and now social prescribers. And I think you really need to think about that, how we inform the public better about all the support services that are around. And how, you know, just, that's a really big issue to me, that's all I'm saying. And I think it has to be addressed because it is very confusing and actually quite a risk. In the past, my speciality here was patient safety. And it's a real risk, actually, if people don't understand who they're actually working with and advising.
Yeah, I mean, just very quickly to come in on a little bit of what NASP's role is within that, in terms of that is part of our responsibility, is to raise awareness on exactly what social prescribing is. And as such, we recently had a Social Prescribing and Me campaign exactly for that reason. And Tracy alluded to it in her talk, didn't she? If social prescribing isn't actually going to attract children and young people, because what does that actually mean? And I used to be a link worker. I used to have that conversation day in, day out. Who on earth are you? Why am I talking to you? But as soon as you start to sort of say to people, what do you think it means? What does it mean to you? That is actually a really good way of opening up that conversation. But I agree with you. More needs to be done to get that kind of change that public perception of what our health service is there for. Is it a sick care service? Is it a healthcare service? Going back to some of what Hamad was talking to earlier, and actually what responsibility do individuals have on their own health and well-being, rather than just relying on their GP to fix everything. But Giles, did you want to come in on?
Yeah, I mean, just to say, I before I joined the charity sector, I was instrumental in helping roll social prescribing out across Greater Manchester. And one of the challenges we had then, and it was before NHS England started funding GP primary care networks to adopt social prescribing, was where best to situate it as a service. Because most local authorities will have typically between 1,000 and 1,500 local community groups. And so if you work, as I do now, in one of those local charities, you think you've been doing this for decades and it's nothing new at all. What's new is that the NHS is starting to see the importance of it and put in place mechanisms to connect. So now that link workers are rooted in GP practices, I really think they need to be thought of as healthcare professionals in the community. And so what I would hope is that within a GP practice, colleagues get to know that they have a social prescriber, that they have a service there, because most people that need support will probably, not all people, but will probably interact with their GP practice at some point. So if the other members of the practice, and not just the GPs, but the practice nurses and other colleagues in the practice know that, then you make that connection. What I don't think works is when you expect the GP practice to connect somebody direct. When I was setting up in the Greater Manchester, I remember going into one GP practice and there was 2 tables in the reception area covered with leaflets for lots of different community groups. So many that they were falling on the floor, and I was like, what are you doing? And they said, well, we're trying to give all this information to our patients. I'm like, well, you're not going to suddenly become the expert in 1,500 community activities in 5 minutes. You need to have a professional here, and that's their job. And then that's the role, really, helping somebody navigate what's out there, but to do it in a way that makes it connected to them personally, because not everybody's going to want to do music. We wouldn't encourage somebody to be referred into one of these groups if they don't want to participate in music. So it has to be tailored to the individual.
William, and then Louise.
I think you're right, and I think that one of the problems with all of anything in the NHS is that it becomes an end in itself. And actually, the link worker should be the means to an end, and they should be backing off as quickly as possible. But their job is to link you up with the community. Cormac Russell had a really good, he does a lot of the asset-based community development, and he had concentric circles of different people you meet in your life. So you have your family and your friends right in the middle, and then you have the state on the outside. And he said a lot of communities have got nothing in between. So your only contact now is with professionals and people who've got real problems in the deprived communities, because all the bits in the middle is gone, because there's no more community. And I think, therefore, you do need that link worker, because they're part of state, to then fill up that gap in the middle, and then they back off. And I think we just, like anything, I've stopped doing consultations now as a GP. I do conversations, because I think my humanity of being a human is probably far more important than the nonsense I do with some of the medicines I give out, etc. And I think, again, rather than have a label all the time, they're just human beings helping you navigate into a world. And I think we should be kind of taking away some of those badges a little bit as well.
Just to follow on to that, I was going to say something similar around language. I think it's really important that we use the terms or the correct language and communications and have people based in different areas, not just within the health sector, such as the GPs, like you said, but myself and a couple of the other national leads on Wednesday, we went to see East Staffordshire PCN, and they have a fantastic model and demonstrated how having link workers not only in the GP practices, on the edge of the local football club, and all sorts fully integrated into the police services was a proper holistic approach to it. And then there was that feedback mechanism. So if they then did need more acute support, it could go straight back into the health system, but then otherwise it would slowly go back into the community. And I think looking at some of the other models across the country, we can really learn how to adapt and make sure it's fully integrated into our society.
Thanks, Louise. Dan just wanted to come in, and then we've got time for one more question just at the back over here.
I just wanted to make the point, though, that I think perhaps unknowingly, when we created the social prescribing link worker role, we created an entirely new role, not just within the NHS, but within the UK, i.e. somebody who has no axe to grind other than what the patient or the client says most matters to them. There is no other professional in Britain who has no agenda except the agenda of the client, and that is the social prescribing link worker, who genuinely, disinterestedly is not trying to get them into a job. They're actually not trying to get them to improve their health either. They're trying to do whatever matters most to that individual. It's not about going out jogging in the morning or stopping smoking or losing some weight or getting a job or learning English or learning how to use a computer. It is whatever matters to that individual in that conversation with the social prescribing link worker. There is no other professional in the UK who has that freedom to support somebody with what most matters to them. But this is also why the social prescribing link workers need to have decent consultation or conversation times. Link workers will often tell you that their clients reveal something to them that they have never spoken to any other human being about ever. But that's usually on the second, third, or fourth session, where they've had 3 or 4 hours with the link worker at that point and built up the confidence and trust to really talk to them about really what matters to them, and something that might have happened in their childhood 30, 40 years ago even. Yeah.
Thanks, Dan. Sorry, we've just got time for one more.
Just quick, it's not really a question, but one of my opinion is that really the word resilience, as the GP was talking, should be changed and seen as opportunity, because when we see the word resilient is, it's because I'm not well. But if we see the word opportunity, we have the opportunities to do something. And this word has to be also put for the NHS in general, because the mentality is that, social prescribing is no good at all. Let's go to the science, let's focus more in psychiatry, medications, social prescribing, take out of the panorama. So I think that really the change has to come by opportunities. Thank you.
I think we're going to leave it there unless anyone wants to come back on that point. Thank you for our final panel. That was really rich, and I'm sorry that we didn't get a chance to come to every single question, but I do encourage you to keep the conversation going amongst yourselves and also with NASP. We're always happy to engage and connect you with other services that might be able to have some of those have the answers to some of those questions. I'm just going to hand over for our final remarks from our CEO, Charlotte Osborne-Ford.
Sitting down for too long. What an absolutely fantastic event. And although I obviously know all of our speakers and I've heard from all of our speakers before, I learned something every single time from everyone that's spoken and feel really re-energized and re-inspired. So a huge thank you to everybody that has spoken. And of course, to everybody that was involved in organising the event and putting it together. I think there's a few things that really stood out this time, and I think there has been lots of reflection on quite how rich and complex the work is that is going on, how it's been recognised across the world and duplicated across the world. So we really have made a vast amount of progress, but equally so much more to be done. And whenever I hear Deb speak, I always think of the moment you talk about, well, you picked up a leaflet. What if you hadn't picked up a leaflet? we shouldn't be waiting for people to pick up leaflets. We should be integrating this with every element of medical care. Every time you see somebody in the NHS, you should have the opportunity to have that conversation. So we've got miles to go. And a few other statistics. Giles, you said 2% of people with dementia get to access the offer from Camerata. 2%. And then I think somebody else shared a statistic, was it 97% of the investment from DHSC goes into clinical services. So we've got a very long way to go to move towards equity, but we're making really good progress. So if there was a word around hope that was used earlier, I think today's been really hopeful. We do have a new government. There is opportunities to shift the traditional way of doing things. So I really hope that we can continue to work together to do that. One easy way for you to do that is just to make sure you're following us on social media so you can keep up to date with all of the latest reports, the latest evidence, the latest opportunities to connect. And also you may wish to consider becoming a NASP social prescribing champion, which is open to everybody working in the NHS to again more formally advocate for this within your clinical practice and within your work. But thank you so much for joining us today. Thank you to everyone who added questions and comments, and thank you to our speakers, and safe journey home.